2, 1. Please start, sir. We are live.
Hello, good evening, everyone. It's a pleasure to welcome you all on the day 2 of Hematology Update 2022, which is going to focus on updates from EHA 2022. It's a pleasure to welcome you all and a pleasure to welcome Dr. Upendra Sharma, the program convener. Sir is a senior consultant hematologist and hemato-oncologist at the prestigious Bhagwan Mahavir Cancer Hospital, Jaipur. So with this word, sir, good evening, Dr. Upendra Sharma, sir. We invite you to set the ball rolling with the context setting. Over to you, sir.
Thank you, Tarunji, for that kind introduction. So today we have a second day of our Hematology Update 2020. So what has happened recently at EHA 2022, the latest happening there in Vienna, Austria. So today we have eminent speakers across the country and esteemed moderator and panelists who will take us through the journey of various hematology disorders. It is my great pleasure to invite Dr. Pnh sir. He is my teacher, mentor. He has taught me various aspects of medicine and hematology. He is presently working as a professor and head Department of Medical Oncology at Mahatma Gandhi Medical College and Medical Sciences and Technology, Jaipur. Over to Pnh sir for your introduction, for welcome and introduction.
Thank you very much, Tarun and Upender. It's a pleasure and privilege for me to be part of this hematology update. My only request to Upender is that I wish he had made a physical meeting so that we could have met face to face. And the face to face discussions are so much better than the virtual discussions. But anyway, that is for next year.
Yes, sir. We'll do definitely, sir.
My personal welcome to all the people who are participating in this hematology update. Day 2, we've had a very eventful, very nice day 1, very important topics discussed and really high quality discussions, which I think must have benefited the faculty as well as the residents who were lucky enough to attend this. So today we are going to cover some more topics. Primarily, we will cover some aspects of CLL. We'll do a panel discussion in which we'll thrash out the advances which have happened in CLL at the recent EHA meeting. And today we will also discuss some aspects of myelofibrosis, bone marrow failure syndromes, and then we will finally wind up with talking about the recent advances in follicular lymphoma. So once again, welcome to day 2, and I'm sure that today's deliberations are going to be as good, if not better, than day 1. So over to Dr. Upender, who is my very, very dear friend and one of the finest hematologists, not only in Rajasthan, but in the country. So Upender, back to you, and many thanks for involving me in this program. Over to you.
So thank you, sir, very much. Your blessings are always with us. So now we have our first speaker, Dr. Mukul Agarwal. He is assistant professor in clinical hematology at All India Institute of Medical Sciences, New Delhi. He will be talking about CLL EHA 2022 updates. Over to you, Dr. Mukul Agarwal.
Thank you, organizer. Thank you, Dr. Upendra, for giving me this opportunity. I hope my slides are visible in the slideshow mode.
Yes, sir. Absolutely.
Sure. So, with respect to CLL, EHA.
So, Gitika, I think video is not working for Dr. Mukul Agarwal and others also.
Okay, just wait, sir. I'll check.
Okay. So, EHA 2022 had a lot of updates about CLL, and so this was important as a lot of new drugs were discussed and a long-term follow-up of the available therapies with us were also presented to at the EHA 2022. If we look at the various updates which I'll be presenting over the next 15-20 minutes, we'll see that the long-term data of important BTK inhibitors like ibrutinib, acalabrutinib, venetoclax, and the combination, as well as certain new drugs, the new BTK inhibitors, and as well as CAR-T were presented at the EHA 2022. So I'll be starting on with first with the long-term data of the previous trial which were there, which were presented abstracts oral or postal, and subsequently moving to the newer drugs as well. Okay. So this is about the real, let's start on with the ibrutinib. This is the real world data from the German reality study. What they had was 2-year follow-up of the patients on ibrutinib as first line, second line or third line, that is C1, C2 and C3 cohorts. Overall around 100 patients in each cohort. And what they told that the retention time in the first cohort, that is de novo cohort, was maximum. And as the line of treatment increases, the retention of the patient on ibrutinib is lower, and so is the PFS and the OS benefit was seen across the 3 lines. So 1-year PFS and 2-year PFS were of the range of 80 to 90%, which is pretty handy, and the overall survival maintained throughout the group, all the 3 groups. We'll see in the subsequent slides as well that overall survival per se in CLL has been consistently more than 90 to 95% in most of the studies. It is the PFS and the MRD which will be discussed in the most of the subsequent studies. This is about the IFCG drugs, that is ibrutinib in combination with fludarabine, cyclophosphamide, and obinutuzumab. What they have shown, this is from the MD Anderson group in the patient with mutated IGHV and without deletion 17p or TP53. That is a good risk patient. In this, limited duration therapy was given. If the patient were MRD negative by cycle 12, they were supposed to stop the therapy. Okay, what we have was that after 3 cycles of IFSC, 97% of the patients were able to achieve a undetectable MRD in the marrow, and most of them were achieving undetectable MRD by 12 cycles. PFS and OS were excellent, 97% each. There were no progression or Richter transformation. All the 41 patients who achieved MRD negativity and completed 12 months of therapy, they were stopping the ibrutinib and were on follow-up. Of these, around 6 patients relapsed without the clinical evidence or clinical indication for treatment. So this is an important study which just goes on to show that limited duration of this drug combination in good risk patient is able to give you a 5-year PFS, which is nearly 100%. Then there is the 6-year data of venetoclax. In this study, they analyzed the venetoclax treated 17p deleted patients for various mutations. And the common mutation detected were TP53, Notch, ATM, BRCA1, BRCA3 mutations. And we can see that the overall survival advantage was maintained. So was the PFS, around 80% in the cohort. And what is additional to be seen is that in the patient who achieved CR, the median PFS was around 62 months versus the patient who achieves a nodular PR or a partial response, the median PFS was 27.6 months only. So the achievement of CR was considered to be important prognostic factor as per this study. But there was no significant differences in the overall response rate, PFS or overall survival with respect to TP53 deletion 17p or the other mutations. One mutation which standard out was mutated SF3B1 in this cohort of patient. Median progression-free survival was shorter. Then I come to CLL14 trial. This is a trial about uses of obinutuzumab with venetoclax versus obinutuzumab with chlorambucil. You can say a slightly handicapped control arm. So we can see that overall and the progression-free survival curves nicely spreading out. Very good differences in the overall survival and time to next treatment as well. So 5-year time to next treatment was around 72% in the experimental arm versus only 43% in the control arm. And overall survival was maintained, as I already said. One thing important which we can notice in the CLL patient is the incidence of second primary malignancies. This is pretty high. If you look at this, around 20% of the patient in the Ven-OB arm and 15% of the patient had SPM. So this is something a cause of worry for many of these patients. But we understand that most of these patients are elderly patients, so there are chances of SPM in these patients, which warrant proper monitoring and overall surveillance. This just goes on to show that the patient with MRD negativity had a far better survival. And the mutations, what was the topic for this abstract? This goes on to show that patient who had MRD negative by 10 to the power minus 6 had entirely different set of mutation as compared to the patient whose MRD was positive. Then I come to the Captivate trial. There is this 3-year data. In the Captivate trial, what they did was 3 months of ibrutinib followed by 12 cycles of ven and ibrutinib. CR was achieved earlier in the 56% of the patient, which increased to 57% by 3 years. And the median duration of CR was not reached. And 12 months estimate was around 94%, which is a remarkable figure for any patient of CLL. What they were able to show that almost 80% of the patient were having undetectable MRD by both blood and or bone marrow, and PFS at 36 months was 88%, which is similar irrespective of the high risk profile of the patient, whether it was 17P, TP53, or unmutated IGHV. Most of the patients were achieving an excellent PFS and overall survival benefits. And again goes on to show that the various high-risk mutation of the BTK, BCL2, and PLCG mutation, which are known to confer resistance to these two drugs, were not observed at 3 years. So there is a good possibility that subsequent retreatment with the same drugs can be given in these patients as well. So this is something heartening that even after stopping the drug after 1 year of therapy, 3 years, there were no mutation developing in these patients with excellent PFS, and a possibility, if at all the disease comes back, the same drugs can be given to the patients again. This is the FLAIR trial in which FCR was compared with ibrutinib and versus venetoclax and ibrutinib. This is a pretty important trial for our scenario where, at least in my setting, this is something which we are commonly using, the first two drugs. And with the more availability of venetoclax, this can also be given. The third arm can also be given to the patients. So in this trial, just a thing to notice is that if the patient were having persistent MRD negativity, as demonstrated by blood and marrow findings, that is taken as an MRD negativity from the first time the MRD was negative shown to be in the peripheral blood. What they were able to show that overall responses were excellent, 86% and 88%. CR, as expected, were higher in the venetoclax combination arm, and most of the patients in the ibrutinib arm had PR only. And again, this is important that ibrutinib arm hardly had any MRD negativity, and around 70 to 75% of the patients in the IV arm had MRD negativity either in the marrow or in the blood. Side effects profile, we will look that addition of venetoclax was primarily leading to more of the cytopenia kind of side effects and additional diarrhea in this patient and nausea. In addition, there were other side effects which were commonly seen were mouth ulcers and dyspepsia. And the ibrutinib arm didn't had any MRD negativity, so none of the patients were stopping the drug as per the MRD negativity stopping rules. But a lot of patients were able to stop the medicines beyond within a fixed stipulated time if they were having MRD negativity in the IV arm. So almost 42% of the patients were able to stop the drug in these patients. This is again an important trial, the GAIA trial or CLL13 trial. This is again important for our setting where we are using FCR or BR as a chemotherapy drugs or venetoclax rituximab commonly in the resource constrained setting where the third arm, obinutuzumab arm, is not possible for many of our patients, and the over so costly ibrutinib, venetoclax, and obinutuzumab arm. This was compared in almost like a 1:1 analysis. Fixed duration of therapy. The distribution of patients and the risk profile was almost similar. What they were able to show that undetectable MRD in the peripheral blood at 15 months. This was maximum in the 3-drug arm. Second, the Ven-O arm was pretty close with almost 86% negativity. The other two arms, chemotherapy arm had nearly nil, and when our arm has also had a 57% MRD negativity in the peripheral blood. We look at the 3-year PFS, the 3-drug arm and the 2-drug arm, when O arm, they stand out and the other arms are just slightly behind. The 3-year PFS were around 90 months, 90% in the 3-drug arm and the when O arm, and it was around 75 to 80% in the VEN-R and the chemotherapy arm. This was irrespective of the IGHV mutation status. The high-risk patient had the similar rate, but the mutated patient had near clubbing of all the 4 arms, with the overall PFS ranging between 85 to 95%, which is pretty handy for most of our patients. If we look at the subgroup analysis, most of the patients, high risk, whether it was complex karyotype, cytogenetic subgroup, IPI or IGHV, all the patients were benefiting from the 3-drug or the 2-drug arms. Overall survival, as I had said earlier, this is a kind of a pseudo mean only for CLL patient, but no, it's similar across the treatment arms. So overall survival was not impacted by either of the treatments. If we look at the safety, this is again something important. So when you're increasing the intensity of the drug, the safety aspects come into being, and the addition of ibrutinib is leading to more hypertension. Venetoclax is leading to more tumor lysis, infusion-related reaction with the obinutuzumabs, and febrile neutropenia again more with the VEN and the triple drug arms. So these are kind of expected side effects with the triple drug regimes. Last but not the least, I like to point out again that in this study as well, good more than 10% of the patient in almost all the arms were having second primary malignancy. This is something which many of us miss and require a close surveillance. Next, I come to the acalabrutinib studies. In this study, acalabrutinib or idelalisib with rituximab was tried against BR in the relapsed refractory setting. What they show was that PFS was significantly prolonged in the ACAL arm as compared to the IDR or the BR arms. So PFS was not reached in the ACAL arm versus 16.8 months in the other 2 arms. Patient with the 17P unmutated IGHV, they had a better survival with a better PFS with the ACAL. OS was not significant as is expected, and adverse event leading to discontinuation, these were far more common in the IDR arm, which is again kind of an expected thing. The other 2 arms were having a similar rate of drug discontinuation. Now come to the Elevate TN, the 5-year update of this trial. This is done in the treatment naive CLL patients. 3 arms: acalabrutinib alone, acalabrutinib with obinutuzumab, and obinutuzumab with the chlorambucil. Poor control arm again can be said. So that risk stratification and the other things were similar. Again, so what we have here is that the median PFS in both the arms with acalabrutinib was more than 75% at 5 years. This is a significant number. As in the third arm, it is only 20%. So 84 and 72% with acalabrutinib, which is a remarkable figure for these patients. And this is similar number is seen with the TP53 mutated or del17P. That the addition of obinutuzumab is not benefiting in these patients as such. And the proportion of patient with the CR or overall response, that is slightly higher in the 2-drug arm. A similar slide with the MRD negativity, we see that with the 2-drug MRD negative, undetectable MRD was around 42% with the addition of obinutuzumab. As is expected, most of the patient with BTK inhibitors do have a partial response, and the MRD is still detectable in most of these patients. Overall survival is similar across the 3 arms. And side effect profile is also on the expected lines only. What we understand by now that diarrhea and other things, neutropenia, they are more commonly seen with the addition of venetoclax. And with the ACAL being present, the cardiac events, bleeding events, and hypertension were more common than the comparable arm. This study again goes on to show that as compared to obinutuzumab and chlorambucil, the incidence of second primary malignancy was pretty high here, almost like 15 to 20%. Next, shifting the gears to zanubrutinib, we have this Sequoia trial in which zanubrutinib was given as in a phase 3 format. What we have here is that this study was mainly about health-related quality of life, and various scales were used, and they go on to show that by week 24 in patient without 17p deletion in first cohort who received zanubrutinib or BR, what we have that most of the patients were having a better health-related quality of life with zanubrutinib as compared to BR. Pain was slightly better by week 12, as is expected with a chemotherapy-based regime, which leads to quicker reduction in the nodes and other things. But the rates were similar by 24 weeks. Then slightly a comparative study between zanubrutinib and ibrutinib. Similar kind of a study, phase 3 Alpine trial. By cycle 7, they were able to show that on both these parameters, EOTRC, QLG, C30, and EuroQL, EQ5D scales, zanubrutinib was able to perform better. Physical function and role function was also better, and the greater reduction in the side effects was also seen with the zanubrutinib. It was probably because it was able to alleviate the disease burden earlier than ibrutinib, and likely that the incidence of adverse event was slightly lower with zanubrutinib. Last, I came to the newer BTKs, that is piribrutinib. We know that almost like 40 to 50% of the patient of the relapse and the frontline setting CLL patients on ibrutinib have to discontinue therapy because of various possibilities, be it resistance or intolerance. In such scenarios, this drug has shown to be of a very good, showing a pretty good PFS benefit. If the patient had received 3 prior lines of therapy, the PFS was not reached, and if they have received 5 prior lines of therapy with the venetoclax being there, the PFS was around 18 months.
Sir, a small request. Sorry to interrupt. You have got another 2 minutes to conclude.
Yeah, sure. Just last few slides. In this slide again, pirtobrutinib was given in combination with venetoclax plus minus rituximab, and overall responses were seen in almost all the patients. Partial responses, almost more than 90% of the patient. No additive toxicity, no dose-limiting toxicities were seen. This is a new BTK inhibitor, nemtabrutinib. And this again, they were able to show that overall responses were almost 58% in these highly pre-treated patients. Lastly, CAR-T trial, Auto-1. In this, 3 patients of CLL were given CAR-T therapy. Of these, 2 of the 3 evaluable patients achieved MRD negativity, remission in the bone marrow with residual small volume lymph nodes by 6 and 3 months of follow-up respectively. So to conclude, I would like to say that many important trial data were presented. These are the various takeaway points from the trial. Elevate TN and CLL13 were important trial, something which are of potential use for us. CLL14 was also good. FLAIR is able to show that MRD negative can be achieved more with IV more than I. And new drugs, piribrutinib and the other drugs are upcoming. Zanubrutinib has slightly advantages as compared to the quicker responses perhaps and better quality of life as shown in the Alpine and the Sequoia trial. With this, I like to conclude and stop my screen share. Thank you.
Thank you, Dr. Mukul, for that wonderful talk on what had happened in CLL in ER 2022. So you've covered all the aspects of the latest advances in the CLL. So now we'll move to our second session, second part of the session. So we will be having a panel discussion that will be moderated by Dr. Pnh Clone. He is professor and head Department of Clinical Hematology and Medical Oncology at prestigious PJ Chandigarh. He will be having eminent panelists with him. So over to Dr. Pnh Clone, sir, and please introduce your panelist. Sir, you are you? Pankaj Malhotra, sir.
20. Am I audible?
Yes, sir, you are audible, sir. Please,
So-
sir, introduce your panelists.
Yeah, I'll introduce. Before I start the things, I'll just apologize because there is a heavy rain which is going on in this part of the country. So the internet connection may be a little bit unstable. So I may, stop my video so that the interconnection is continuous. So the topic is optimal sequencing of therapies in CLL, and let me introduce my panelist, Dr. Amrita Ramaswamy, who is consultant hematology, oncology, and stem cell transplant from Artemis Hospital, Gurugram. Dr. Amrita, are you there?
Sir, I am here for the same reason that you said I'll keep my video off because of the heavy rains.
Okay. Yes, thank you. Welcome. And Dr. Akanksha Garg, Associate Professor, Department of Medical Oncology, AIMS Jodhpur. Welcome, Dr. Akanksha.
Thank you.
Then Dr. Pankaj Tantia, Consultant Hematology Oncology, Acharya Tulsi Regional Cancer Research Institute and Treatment, Bikaner.
Thank you, sir.
Okay, thank you. Welcome. Dr. Hamza Dalal, Associate Consultant, Department of Hematology, Fortis Hospital, Mumbai.
Yes, good evening, sir. I am present, sir.
Good evening. Thank you. Welcome. And last, our dear Dr. Lalit Mohan Sharma, my dear colleague, Senior Consultant Hematologist and Medical Oncologist, Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur.
Sir, thank you so much. I am there. But again, if the rain doesn't allow us to speak much, my request will be that you continue in whichever way you can teach us. It's always a lovely pleasure to listen to you, sir. Thank you so much, sir.
Thank you. I welcome all the panelists, and we will just discuss what we practice as a routine. So we'll go by a case presentation of a 56-year-old gentleman who has come with complaining of generalized lymphadenopathy and B symptoms in the form of fever, weight loss, and some night sweating. It's a little bit uncommon in CLL, but it is still, some patients do complain of some of the B symptoms. So on examination, this patient had hepatosplenomegaly, liver of 4 centimeters, spleen of 6 centimeter, and generalized lymphadenopathy, cervical, axillary, and inguinal lymphadenopathy, and the maximum size was 3 into 3 centimeter. A CBC which was done showed anemia, hemoglobin of 8.9, high WBC count 54,000 with 90% lymphocytes, and platelet counts also, which were on the lower side, 90,000. So since this is on CLL, so I have taken directly a patient who is clear-cut patient of chronic lymphocytic leukemia. Now at this age, he also had comorbidities in the form of essential hypertension, which is controlled, and type 2 diabetes mellitus, which is also controlled on oral hypoglycemics. The investigations, before we actually go to the sequencing of therapy, I think it is very important to understand that, how many investigations do we do, and whether these investigations have anything to do with the treatment which we are offering to these patients. So let me go one by one to my panelists in the way I have introduced, to them about commenting on the investigation like ultrasound, chest X-ray, CT scan, or a PET CT scan. So first I will go to Dr. Amrita.
Sir, I would probably do a PET CT scan in those patients who are saying that they have an increase in the size of lymph nodes in one particular area, or people who have a high LDH, just to rule out a Richter transformation. So in any patient in whom I may kind of suspect a Richter transformation, I would ask for a PET CT scan. Apart from that, I don't think I would do any of the other investigations.
All right.
In a case of CL.
In a case of CL. Thank you. So, Dr. Akanksha, do you agree or do you have some difference of opinion?
Sir, in all the patients, most of the time, if I don't feel that if it's a transformation, I would just maybe just go with the ultrasound of the all the regions just to map out the disease in the form of, the size of the lymph nodes besides the physical examination. But other than that, I would not do any other imaging studies at present, because I know that this particular patient will be monitored on the basis of his count and the bone marrow response rather than the physical examination rather than any imaging.
So where do you then, if you are suspecting, let's say, Richter transformation, so Dr.
Yes.
Akanksha, what would you do then? Would you do a
So
PET CT or?
Yeah, yes, sir. So for that, I would do a PET CT to get just the idea of, which of the particular nodes would have the maximum FDG avidity, and which I would pick up for my biopsy for these particular patients.
Right. Okay, so Dr. Pankaj Stantia.
Sir, I am agreed with Dr. Akanksha. We'll go with PET CT if we suspect Richter transformation, because it is really not possible to do PET CT in every patient of CLL. Most of the patients of CLL are not in Richter transformation. It is rarely found in CLL cases, especially the new presenting case of CLL. So
right.
I will go for other investigation like ultrasonography, or ultrasonography is, I think, enough for this case. Add on to this, I will go for a 2D echocardiography to decide the drug of choice for this patient.
Okay. Dr. Hamza and Dr. Lalit, any difference of opinion or anything you want to add? Otherwise, we go to the next questions. Dr. Hamza, anything?
Nothing, sir. At baseline, we would do a chest X-ray and ultrasound abdomen and a 2D echo, but no CT imaging at baseline.
No CT imaging. Right. Dr. Lalit, anything else?
Yes, sir. I think, sir, if you do a PET CT scan in subset of patients, because many are having pulmonary tuberculosis, sometimes we are putting them in immunosuppressive drugs. So if you do a baseline assessment, it is always helpful, but not mandatory. So basic bare minimum need is of X-ray and ultrasound. But if finances are not a barrier, and if you feel that patient is already a diabetic and might be having some pulmonary infection which may flare up, so it is better to do it.
Right. So I think, sir,
one important thing I want to point out. I think, sir, bone marrow examination in such cases can be avoided. We maximally see in these cases bone marrow examination is done, but it can be avoided in these cases, as maximum investigations can be done on blood samples only.
We'll just come to that in my next slide. So I think here, whosoever the fellows or the residents who are listening to this, so you can see that almost all panelists are on the same page that as a routine, a clinical examination is good enough in a patient of CLL, and ultrasound and a chest X-ray otherwise can add to your baseline investigations, in the sense that sometimes tuberculosis or other infection you want to say, and ultrasound is otherwise a good modality to see, just to document the size of the liver and spleen if you are not very good in clinical examination, or if the patient is obese and you are not sure what is the size of liver and spleen in that particular patient. PET CT is only required if you are suspecting a Richter transformation, and generally SUV value of more than 7 or 7.5, you would biopsy that lymph node and see whether there is a Richter transformation or not. Now, the other important question about the lymph node biopsy flow, bone marrow and FISH, which Dr. Pankaj was talking about. So maybe we again go from Dr. Amrita. Can you comment on these investigations in a patient of CLL, especially, this patient where this patient has B symptoms and some anemia, thrombocytopenia?
Sir, a lymph node biopsy, definitely I would not do. If the peripheral blood shows lymphocytosis, I would do a flow cytometry on the peripheral blood to confirm diagnosis. I would not do a lymph node biopsy.
Right.
And a bone marrow, I usually do not do at baseline if the counts are normal. And a FISH I usually do only when there is an intention to treat or when the patient actually fits criteria for CLL treatment. And IGHV mutation also I do not do unless the patient fits criteria where we'll have to start treatment for CLL.
Okay, thank you. So Dr. Akanksha?
Yes, I completely agree with Dr. Amrita. My approach is the same as hers.
Okay. Okay. Now, Dr. Pankaj, you are talking about the bone marrow, and specifically
Yes,
now
sir.
we are discussing this patient where this patient has anemia, thrombocytopenia. So, do you think marrow is required, or you would say no, there is no need?
Sir, I will discuss one by one. Sir, since patient is in a stage 4 CLL, so in this case, lymph node biopsy, we don't need it. Flow, fish, IGHV can be done by blood. And we don't need a bone marrow examination, as every test what we want to see through a bone marrow can be seen with a simple blood sampling. And one more thing, sir, we need an IGHV mutation in this case because we need to start the treatment. We need to plan the treatment of this patient. So I will go for IGHV mutation in this case before starting therapy.
In this patient. Okay. Dr. Hamza?
Sir, in this patient, considering the patient has cytopenia, and we would consider the starting treatment, we would obviously evaluate this patient to see whether the patient's direct Coombs test is positive. So if this is a autoimmune type of cytopenia, then obviously the patient can be treated with steroids and we can avoid treatment at present. But if the patient's DCT is negative and we are actually considering therapy for this patient, I think it might be worthwhile to do a bone marrow to document that there is disease infiltration and cytopenia because of that, and then initiate the patient on the treatment. About the FISH and IGHV mutation at baseline when the patient first presents, ideally, if you want to calculate the CLL IPI and we want to prognosticate the patient, whether the patient will require treatment soon or later, it is better to do it off. But if the patient is not affording, or if we are not able to do it for any other reasons, then when we decide to treat the patient, at that time we should get the evaluation done.
Right. Dr. Lalit?
So I think, sir, in addition to whatever has been discussed, TP53 mutation testing is also, in fact, needed because we are going to start treatment in this patient.
Okay, so let me come back. Yeah,
if I can add something. So if we have a CLL patient who has an anemia with a low retic count and a DCT that's negative, sometimes we do have rare, like a pure red cell aplasia, so that can be picked up only on a bone marrow. And sometimes even without treating the underlying CLL, you can just get away with treatment of the PRCA with immunosuppressive drugs. So maybe if I'm suspecting PRCA based on other lab parameters, I would do a bone marrow aspirate and biopsy in a CLL patient.
Excellent. Dr. Pankaj, you want to say something?
Sir, there is 1% chance, less than 1% chance of PRCA in CLL.
No. The question is, if you are suspecting PRCA, would you like to do a bone marrow examination or not?
If I will suspect PRC, then I'll go for it. But I think it's a rare, very rare, race of the rare entity. So,
it all depends how many CLL patients do you see in your practice. So if you see, like in an institute like ours, if you see a lot of CLL patients, then, you would do marrow examination in quite a good number of patients where you are suspecting either a PRCA, or if you are not clear about the cause of cytopenias, if the patient is developing that, and many times,
we did study on CLL. We did bone marrow examination, especially biopsy of CLL patients, those who were suspected. We did biopsy of 100 patients, and we didn't found it in any one of them. So we closed it, sir.
No. So it's okay. So it's the clinical scenario, and since we are discussing all patients and the residents are also listening to it, so we should be clear that exactly as a routine, you don't require a bone marrow examination in these patients, and it's only a rare situation where you suspect a PRCA, or if the cause of cytopenias is not very clear and you are suspecting that something else is there, or you are suspecting Richter transformation and your PET CT and other investigations are not showing that, then probably there is maybe a role of a bone marrow examination. Otherwise, as a routine, you don't require. There is a controversy among the panelists to do a FISH test and a IGHV mutation in an asymptomatic patient of CLL, but definitely everybody agrees that you require these investigations once you think that the patient requires a treatment. For example, in this patient who has anemia, thrombocytopenia, generalized lymphadenopathy, B symptoms, so you will do a FISH test and IGHV mutation in this patient. Flow, obviously, you require in all these patients, and a lymph node biopsy very rarely. If you are suspecting Richter transformation based on a PET CT or the other symptoms, then you would like to do. Dr. Lalit, you have raised your hand. You want to say something?
Sir, in this particular patient, since it is bicytopenia, so again, I would like to do a bone marrow before starting the treatment.
Okay. Fair enough. So now, we have made a diagnosis and we are, all the panelists are clear that this patient requires a treatment. So now, based on what Dr. Mukul Agarwal has discussed, so we discuss about the practice of our panelist. So maybe we can start from Dr. Lalit. What is your opinion and what is your practice of treating a CLL patients? And we are talking of a patient who is affordable. So what is your practice in your clinic?
In fact, sir, for such patient, ibrutinib, if patient's affordability is not an issue, but since in Rajasthan, most patients are covered under some government health scheme plan, so the commonest things available in that plan is B plus R. So we use that more often in that subset. Otherwise, ibrutinib usually we started.
Okay, so what I gather from you is either you will give BR or you will give ibrutinib to your patients. And how do you decide whether to give BR or ibrutinib? Dr. Lalit, if you can just clarify, how do you decide whether to give BR or ibrutinib? Dr. Lalit maybe not able to hear that. So we go to Dr. Hamza. Dr. Lalit, yeah, please. If you can just clarify, how do you decide whether to give BR or ibrutinib?
So, sir, in patients where we want to have some fixed duration of treatment, we start with B plus R. If the patient is sort of willing for indefinite treatment, and we also feel that this is an elderly person not willing or not fit for the intravenous repeated chemotherapy, then we put them patient on ibrutinib.
Okay. I got it. Okay, thank you. Dr. Hamza?
So the genetic test would really decide which of the race we go. So if a patient who has a deletion 17p TP53 mutation and an unmutated IGHV, we know that chemoimmunotherapy is not going to do a good job, in which case we definitely counsel them for first hand itself for ibrutinib. If the patient has a mutated IGHV and absence of deletion P and TP53 mutation, then they are candidates for chemoimmunotherapy. And considering this patient is a young patient, we might consider either BR or FCR, probably leaning towards FCR. For all the other patients, it is a matter of choice between the discussion with the patient, whatever we want to.
Okay, so what I gather from you is you are still using FCR in your practice?
Very rarely, sir, very rarely. So the thing for all patients, we offer ibrutinib first, but if they want a limited duration therapy and if they are, especially they're fitting, if it's a young patient with a mutated IGHV, then we consider giving them FCR.
Okay, and we'll come back again to all the panelists. So Dr. Pankaj Tantia?
Sir, I will go for ibrutinib first. It is safe, it is affordable, and very easily tolerable to the patients. I can just take venetoclax to add on to ibrutinib, but in India, I don't I don't prefer venetoclax because we are not getting it in India right now. We have to get it from Bhutan or Bangladesh, so I don't trust it basically. Otherwise, the best combination from my side, it will be ibrutinib plus venetoclax, and we can move on to the MRD status. If it is negative, we can just stop it. Other second option for me is, as Lalit sir said, BR is easily available treatment in Yojanas in Rajasthan. So it is a very common treatment for those who are not affordable, who cannot pay for ibrutinib. We go for a BR, 6-cycle BR, and then we put them on observation. So that is the thing, sir.
Okay, thank you. Dr. Akanksha?
Yes, sir. So my treatment sequence would actually depend on the patient factors as well as the disease factors, which have been discussed previously by Dr. Lalit sir and Dr. Hamza. So if the patient is having IGHV mutated status with the absence of deletion 17p and TP53, then this particular patient can be offered a limited duration therapy in the form of BR, which is the most common therapy which we are usually following in our scenario. And if the patient, suppose, has unmutated IGHV, then I straight away advise the patient for indefinite therapy in the form of ibrutinib. Again, ibru and ven combination cost constraints are definitely there. So if the cost is an issue, then my preference is usually to go with the ibrutinib in these patients. And since this particular patient has a controlled hypertension as well as diabetes, again, is not an issue. So I would be comfortable giving ibrutinib in this particular patient if there is IGHV unmutated status or with or without deletion 17p. So that would be my option. And again, it depends on patient's preference as well. And I think that's how I would go about treating this particular patient.
Okay, okay, fair enough. So, Dr. Amrita, any difference of opinion?
Sir, if it is, I think I would rather categorize patients into elderly, unfit, and young and fit. If somebody is elderly and unfit, I would probably not give chemotherapy, even if he or she is IGHV mutated. I would lean more towards a Bruton tyrosine kinase inhibitor, monotherapy, and then maybe reserve venetoclax and obinutuzumab at a later time at a point of relapse. So if it was an elderly unfit patient, irrespective of IGHV mutation or not, I would lean more towards a Bruton tyrosine kinase inhibitor, monotherapy, and then maybe venetoclax, obinutuzumab at a later time. If it was a fit patient, then I'm more interested in doing an IGHV, and then I would offer either time limited if he is IGHV mutated. If he is IGHV unmutated or high risk, if a 17p deletion is positive, then I would definitely give him a Bruton tyrosine kinase inhibitor, and also maybe give him, if he's young and fit, obviously he's a candidate for venetoclax and obinutuzumab as well. So then I kind of offer them and say, do you want indefinite therapy or do you want finite therapy? And then I think I would consider the patient's choice. If it was an elderly unfit patient, I would lean towards the newer agents. I would put a Bruton tyrosine kinase inhibitor first and then venetoclax obinutuzumab later.
Okay, so what I gathered from the panelists is that they would, so the therapy would actually depend on your FISH report, whether it is 17p deletion or not. And the second is looking at the IGHV mutation. And the second factor, they look at whether the patient is young or whether the patient is elderly, and based on that. So one of the question, which is coming to my mind, and I would like an opinion from all the panelists is, when we talk of Bruton kinase inhibitors, so what would you choose, ibrutinib or acalabrutinib? Because acalabrutinib is now also available in a generic version. And although I agree that this may be a little costly than generic ibrutinib, but going by the adverse effect profile of ibrutinib versus acalabrutinib, so let's say you have both the options available. So how do you choose one over the other? Maybe I can start from Dr. Lalit.
So, sir, acalabrutinib, if available and financial is not an issue, that is preferred, sir. Much more safe and convenience and less chance of having AF and other complications.
Right, right. Thank you. Dr. Hamza?
Sir, I agree, sir. If the finances are not an issue, I think all the patients should be on acalabrutinib rather than ibrutinib.
Okay. Any difference of opinion among other panelists, Dr. Pankaj Tantia, Dr. Akanksha, Dr. Amrita? You all agree that if the finances are not an issue, then you would like to, even, patient does not have diabetes, patient does not have hypertension, you would still feel that acala overscores ibrutinib, and you would like to put the patient wherever, you feel that they require a Bruton kinase inhibitor, you would start with an acalabrutinib. I think all the panelists agree with that, or any difference of opinion? Dr. Amrit, you want to say something? Yeah.
Maybe in a younger patient, we could still use ibrutinib without multiple comorbidities and without polypharmacy. Whereas in an elderly patient who's on multiple drugs, has other comorbidities, definitely acalabrutinib. So I think ibrutinib is the drug that has been there longer. We have more safety data for it. In a younger patient, I may not still hesitate to use ibrutinib. Ibrutinib and acalabrutinib probably equally, but in an older patient, definitely acalabrutinib.
And the other thing, since we are using now Bruton kinase inhibitors very frequently means that, in the past, we were using only BR or FCRs or chlorambucil prednisolone or chlorambucil rituximab. But now quite a good number of patients in our clinic are on ibrutinib or acalabrutinib. So one of the question is how much dose of ibrutinib, and if you can share your experience on the dose of ibrutinib which your patients are able to actually tolerate. I mean, we all know that the dose is 420 milligram, 3 capsules a day, but how much dose patients are able to tolerate, and just give a kind of your experience, Dr. Amrita.
Sir, I usually start them on 420 milligram only, but then we do see patients who are unable to tolerate that dose, and I have also treated some elderly patients with as low a dose as 140 milligram once daily.
Right, and what is the percentage of patients which you feel are not able to tolerate? Just guess. I mean, let's say you have 100 patients, so how many patients are on 420 milligram, and how many patients are on reduced dose ibrutinib?
I would say reduced dose 40% and
40%.
maybe
Okay.
40%.
Fair enough.
And then,
fair enough. Dr. Akanksha?
Yes, sir. So my patients usually in CLL have not had any dosage problems and intolerance to ibrutinib. But I would like to share one experience where in mantle cell lymphoma, actually, ibrutinib was not well tolerated in one of my patients. But otherwise, CLL patients are doing well. And I'd also like to add that with acalabrutinib, the advantage is, I think, the incidence of the DTK mutations, the resistant mutations is, I think, lower than as compared to ibrutinib. So given an option, if we have no financial constraints, then I think patients should receive acalabrutinib as compared to ibrutinib.
Okay, Dr. Pankaj Tantia?
Sir, I usually start every patient of my on ibrutinib by 1 capsule daily for 10 days. If patient doesn't have any issue, it can increase by 2 capsule daily per day. If he is quite fit, young, and weight is almost 70 kg or more than that, then I go for 3 OD. I have maximum patient of my on ibrutinib on daily 2 capsules, that is 280 milligram. I am very fear of giving 3 capsules daily because it have a lot of side effects after that. That's why. But almost every patient of my on 2 capsules daily is doing really very well. They are very comfortable and almost they are on that for 5 to 6, almost 7 years, and they are doing quite well on 2 capsules daily.
So that is an important feedback which Dr. Pankaj Tantia has given, that even 2 capsules, this majority of patients are doing well. Dr. Hamza?
Sir, this thing only for the old and very frail patients we started a lower dose, but most of the patients we started 420 mg OD only, and they do tend to tolerate. There are a few patients who have intolerance, but most of the patients are very comfortable at 420 mg OD.
Okay, so your patients are doing well. Dr. Lalit has raised the hand, and Dr. Lalit, it's your turn to share the experience.
Thank you so much, sir. In fact, the exact dose is 3 capsules per day, but I'm big fan of Dr. Varsha Gandhi's paper published long back that even after 3 months, 1 capsule daily is good enough. And I have few very well educated doctor patients, in fact, whom I have kept on 1 capsule daily for more than 2 years plus. So yet, in fact, I'm waiting for more trials, in fact, related to this, that what is the right dose. But most commonly, people do not tolerate beyond 2 capsules. So more than 50% patients are on 2 capsules. Yes, around 40-50% patients are on 3 capsules daily. Very educated, committed, where they trust the literature, and I show them those papers. So they are even comfortable with 1 capsule daily also after, say, 5-6 months or so.
Great. That's a very important feedback, and I think we share the same experience with you. So quickly, can you tell about the dose of acalabrutinib if your patients are, whether they are able to tolerate 100 mg twice daily or 100 mg OD? If there are any patients, if you have any patients on acalabrutinib?
I don't have any experience, sir.
Okay, you don't have anybody. Anybody from the panelists has any experience of using acalabrutinib?
We have just started one patient, then I think 2-3 weeks back, and he has been started on 100 mg OD. So it's too soon actually to say.
Okay, so we have a couple of maybe more than that, and we had a acalabrutinib trial also at our site. So I would say that a very elderly, somebody who is above 85 or 90 years, they are doing very well on 100 milligram per day also. Otherwise, acalabrutinib is better tolerated than ibrutinib, and most of the patient can go on to 100 milligram BD, as opposed to ibrutinib, where even in our experience also, we have seen 60 to 70% patients actually are either on 1 capsule or 2 capsules rather than on 3 capsules. So,
Dr. Pankaj, sir, sorry to interrupt. Last 1 minute to conclude, sir.
No, we have concluded. So I was just making the statement. I thanks the panelists for their important feedback, and I hope all the fellows and the residents who are listening to discussion, they can take home the very important points based on the practical experience of all the our experienced panelists. And I thank all my panelists, Dr. Amrita, Dr. Akanksha, Dr. Pankaj Santia, Dr. Hamza, and Dr. Lalit Mohan Sharma for sharing their experience and giving this feedback. Thank you very much. Thank you.
Thank you so much, sir.
Thank you, sir.
Thank you, Dr. Pankaj Malhotra sir, and all the panelists for that excellent discussion on how we can optimize our sequencing therapies in CLL patients. And very practical aspects has been discussed in this. Now we'll move to our next section. This session is on MPN. And our next speaker is Dr. Pawan Kumar Singh. He is senior consultant, head of department of Meta-Oncology and Bone Marrow Transplant at Artemis Hospital, Gurgaon. He will be talking about the evolving treatment paradigm in myelofibrosis and update from ER 2022. Over to Dr. Pawan Kumar Singh. Dr. Pawan.
Yeah. Thank you, Dr. Upendra, for arranging this meeting and inviting me for this talk. So I'm just going to share my screen. So, and I thank the sponsors, Novartis, for inviting me for this talk. So the topic which I've been given is the evolving treatment paradigm in myelofibrosis. So,
So make the full screen. Thanks.
yeah. So myelofibrosis, this is the usual progression. If we see the early PMF and overt PMF, whether it is post PV or post ET myelofibrosis, then so basically we treat myelofibrosis based on the symptoms, because obviously we cannot alter the natural course of myelofibrosis, which can only be possible by allogenic bone marrow transplant. Otherwise, the usual course of a disease causes the problem related to myelofibrosis, which is usually the thrombotic event, splenomegaly, weakness, and all these constitutional symptoms. So in early PMF, short-term problems are vascular events. So focus is mainly on treatment of this, and the lead time, usually it takes more than a decade to progress to overt myelofibrosis. Then once the overt myelofibrosis or develops, the symptoms progresses to progressive constitutional symptoms, progressive organomegaly, extramedullary hematopoiesis, and progressive cytopenias. So they are treated accordingly, and all these things, it causes decreased quality of life, poor performance score, and the treatment is mainly focused on these. That once there is leukemic transformation, it can lead to premature death and other myelofibrosis related complications. And usually the time variable is between 3 to 7 years. So if we see the disease progression, ET versus early prefibrotic PMF. So this is international observational study. And as compared to ET, the early prefibrotic PMF, the overall survival, the cumulative incidence of transformation to overt myelofibrosis is more in early prefibrotic PMF as compared to ET. Now, the clinical spectrum of this disease is heterogeneous, and so sometimes it is difficult to differentiate between ET and PMF. And ET, progression towards overt myelofibrosis, and usually it takes time. The initial part, ET, is usually associated with bleeding and thrombotic complications, and once the overt myelofibrosis is there, the symptoms are related to myelofibrosis, which leads to decreased life expectancy. So treatment algorithm, if we see the newly diagnosed myelofibrosis, so usually prognostic scoring system is done, and we can use any of the system like DIPS plus scoring. So depending on, based on this scoring system, the patient can be categorized into low risk. Mostly they are asymptomatic patients. We can put them on observation, And the next group is intermediate 1 risk, that they are usually symptomatic, and it's in the form of cytopenias, sometimes leukocytosis or thrombocytosis, anemia, organomegaly, especially the spleen, constitutional symptoms, and other cytopenias. And intermediate to or high risk, and they are usually appropriate candidate for allogeneic stem cell transplant if they are eligible. And if they are not, then they are treated based on the symptoms. And for leukocytosis, thrombocytosis, hydroxyurea, and interferons, these are the options to correct anemia, steroids, androgens, IMiDs like linoderma, especially with deletion 5q, and some investigational drugs like we have currently, like Respatusert. These are the other options, and obviously the transfusion. Then for organomegaly, especially the splenomegaly, JAK2 inhibitor, and the second line alternate JAK inhibitors, hydroxyurea, IMiD, investigational splenectomy. First line therapy for constitutional symptoms, JAK2 inhibitor, and second line treatment, alternate JAK2 inhibitors and other drugs. And other cytopenias, they are usually treated with androgens and IMiDs or sometimes supporting therapy. So basically, if we see for the myelofibrosis, the treatment is mainly based on the need. So like if patient is having anemia, usually they are treated with the ESAs, erythropoietin stimulating agents, then corticosteroids, danazol, and sometimes thalidomide and lenalidomide if the patient becomes refractory to these agents. Symptomatic splenomegaly, this is usually treated with Rexolotlip, that is the first generation JAK2 inhibitor. Then other JAK inhibitor is the fedratinib, hydroxyurea. Sometimes if they become refractory to that, cladribine, IMiDs, splenectomy, these are other options. Constitutional symptoms, they best respond to Rexolotlip and fedratinib. Then steroids are other options. Extramedullary hematopoiesis, they can be treated by radiation therapy. Sometimes surgical treatment if clinically indicated, like if the patient presents with spinal mass with cord compression. Hypoproliferative disease, interferons is a good option. Then risk of thrombosis, low dose aspirin, or sometimes if there is overt thrombosis is there, they are usually treated with anticoagulation. And accelerated and plastic phase hypomethylating agents, and then allogenic bone marrow transplant. So allogenic bone marrow transplant is going to change the natural course of the disease. So it is based on this. Low risk patients, usually they are minimally symptomatic, observation or interferons, then many symptoms, JAK inhibitor. So JAK inhibitor, if you see, and anemia treatment, and these are important treatment in the management of myelofibrosis. So MPN-10 score is there. So total symptom score, easy to use. The patients themselves can use, and it is very important in assessing the response to that. It is mainly based on inflammation, splenomegaly, and anemia. Early stage myelofibrosis may have significant clinical burden. So the prognostic risk score high or low dips. Plus low risk myelofibrosis, they are moderately to highly symptomatic in 44% of cases. So now I'm going to come to the Comfort 1 and Comfort. We all know about Comfort 1 and 2 trial in which the Rexolotlip was used for patients with intermediate to high risk myelofibrosis. So Comfort 1, it was compared with placebo, and in Comfort 2, it was compared with the best available therapy. And the grade, so it was very well tolerated, and splenic size reduction in this, we see that there was significant reduction in the splenic volume, and the total symptom score also, there was more than 50% reduction in majority of patients on Rexolotlip, and discontinuation because of adverse events, it was almost same. So mainly the adverse events were grade 3-4 anemia and thrombocytopenia. So pooled analysis, patient with intermediate 2 risk had overall survival, longer overall survival with Rexolotlip as compared to those with high risk patients. So this is effect on metabolic and nutrition parameters. So there was improvement in terms of serum albumin and mean change in body weight as well. So it improves the renal function in myelofibrosis also. And splenic response, this is very important, plus, and retrospective analysis showed that the splenic response was better in patients on ruxolitinib, and over a longer period of form, this response was sustained. And the splenic response affects the outcome of ruxolitinib treated patient with myelofibrosis. So comfort 1, ruxolitinib efficacy by titrated dose. So this is based on dose, so placebo. So in this, at all doses, once there is increase in dose, there was a significant improvement in terms of response in the form of spleen volume. And this is change, and also in the form of total symptom score. And the usual dose is prescribed is 15 to, and we can see that almost once the dose was increased from 10 to 15 to 20 mg, the response was seen. But once the dose was increased beyond 20 mg, there was not significant difference. And usually less than 10 doses, less than 10 mg PD, it is not effective in long term. This is again very important slide, impact of ruxolitinib on anemia. So initially, once the treatment is started, there is a drop in platelet count, and in ruxolitinib group as compared to placebo, there was more drop in, but once the response is there, usually it is maintained. And this is again very important. Initial 4 to 8 weeks of therapy of starting ruxolitinib, there is drop in hemoglobin, and that does not need to stop the ruxolitinib. In fact, we should give the blood transfusion and increase the hemoglobin and continue as far as possible with the correct dosage of ruxolitinib. And ruxolitinib overcomes adverse prognostic effect of anemia in myelofibrosis. So there was drop in hemoglobin, but anemia worsening cause it is not a signal of myelofibrosis progression and shorter life expectation. So rationale for early use of ruxolitinib for myelofibrosis. This is again a retrospective study, and influence on disease stage and quality of response. More advanced disease and later treatment start may reduce ruxolitinib efficacy. Symptom spleen responses are lower if the interval between myelofibrosis diagnosis and start of ruxolitinib is more than 2 years. Larger splenomegaly and higher total symptom score, transfusion dependency, and intermediate to high risk. So now the other thing is the dose of ruxolitinib. Early myelofibrosis patient may tolerate a higher ruxolitinib dose, and patients starting with higher, as we discussed in our previous slide, that patients starting at higher doses have a higher rate of spleen response, and the use of lower ruxolitinib dose may also results in reduced efficacy. So in fact, less than 10 mg dose is usually not effective. So in IPSS-1 patients, higher response rates and lower toxicity, Comfort 1, 2, 3 trial, then JUMP trial, robust trial, Italian study also. So this is a realized study, safety and efficacy of ruxolitinib in patients with myelofibrosis and anemia. So it's a multi-center study. The starting dose was 10 mg BD for 12, followed by upward titration. So here we see that once the dose was, so usually 20 milligram dose is better tolerated. And realized spleen response also, most patients experience splenic reduction and improvement in patient reported outcomes as well. And week 24 splenic response seen in both total dose and non-TD patients. So impact of honey. Now this is tips of using ruxolitinib. So ruxolitinib is usually indicated for a splenomegaly or myelofibrosis related symptoms, and regardless of the risk of death. Anemia is not a contraindication. So, and if there is initially there is a drop in hemoglobin, so it has to be corrected by blood transfusion. Avoid prophylactic underdosing. Maintain maximum tolerated dose to achieve larger reduction in splenomegaly early during the treatment. And development of anemia does not affect benefits of JAK inhibitors. Manage anemia as alternative to early dose reductions. Avoid abrupt interruption of ruxolitinib in patients responding well. And there is possibility of opportunistic infection, especially in our setting. We have seen many cases developing tuberculosis also, and monitor for skin cancer, which can be seen with long-term disease. In mutation in JAK inhibitor era, so effect of JAK inhibitors on spleen response and symptoms, we've already, it is independent from the presence of JAK2 or any other mutation. Even if JAK2 mutation is not there, the patients can have response. And outside clinical trial, there is no indication to perform serial measurement of JAK2 or other any mutation positivity or allele burden. Rexolotlip provides a survival benefit in both molecularly high risk groups like ASXL1, EZH2, SRSF, or IDH12, and low risk patient. Patient with more than 3 mutations may have shorter time to Rexolotlip discontinuation and shorter overall survival than those with fewer mutations. So now, fedratinib, it is highly selective potent inhibitor of wild type and mutant JAK2 inhibitors, and it also inhibits FLT3. So this is the Jakarta study in which it was fedratinib dose 400 mg once daily was compared with 500 mg and placebo. Primary endpoint was spleen response and secondary endpoint was symptom score. So there is the splenic response with 500 mg dose, 40% of patients had more than 35% reduction in splenic volume. And as the dose mean change in total symptom score, also there was improvement with fedratinib dose of 500 mg. So hematologic and non-hematological toxicity, mainly it is nausea, vomiting, and diarrhea, GI toxicity, and other is the cytopenias in the form of anemia and thrombocytopenia. Indication of fedratinib in myelofibrosis, it is approved by US FDA in 2019 for treatment of adults with intermediate to or high risk primary or secondary myelofibrosis. Recommended dose is 400 mg once daily. Patient with platelet count more than 50,000 reduced to 200 if the patient is taking strong CYP3A inhibitors, or if there is severe renal impairment. There is a black box warning of Wernicke's encephalopathy, which occurred in almost 1.3% of patients receiving fedratinib in a total cohort of 600 patients. Measure and replace thiamine levels before starting treatment, and do not start fedratinib in patients with thiamine deficiency.
Sir, kindly conclude your talk.
Yeah. So allogeneic stem cell transplant, as I mentioned in my earlier slide, it has improvement in terms of survival in all risk categories. And 2015 ELN recommendation, consideration of allogeneic stem cell transplant for all patients eligible with intermediate to or high risk patient with low risk patient who are refractory or transfusion independent anemia if the blast is more than 2% on 2 repeated manual measurements, or if there is adverse cytogenetics or high risk mutations, and transplant procedures should be performed in a control setting. Rexolotlip should be used as bridge to HSCT, which causes because the splenomegaly can cause delay in engraftment, poor graft function, and is associated with high TRF. So I'll just skip this. So pre-treatment Rexolotlip also improves the outcome of allogeneic stem cell transplant in myelofibrosis. This is again slide. So these are selected ASH abstract of these drugs. So I'll just stop here. Thank you.
Thank you, Dr. Pawan, for that wonderful talk on how we can treat patients of myelofibrosis in 2022. So you very extensively covered all the aspects of myelofibrosis with ruxolitinib, fedratinib. Now we'll be shifting to our next discussion. This will be a panel discussion that will be moderated by Dr. Dinesh Burani. He is Senior Consultant and Director, Head of Department. Head of Department. So Dr. Dinesh. Dr. Mahesh, please mute yourself. Dr. Mahesh, please mute yourself.
Yeah.
So we have Dr. Dinesh Burani. He's Senior Director, and he's Senior Director and Head of Department. Department of Hematology at BLK Max Super Specialty Hospital, New Delhi. He will be moderating a panel discussion on clinical evaluation, diagnosis, and treatment updates in hypocellular bone marrow failure syndrome. So over to Dr. Dinesh Burani, sir. Please introduce your panelist also.
Thanks. Whose voice is audible? Is there someone who has opened the... Tarun, can you see that? Am I audible?
You are audible, sir.
Yes,
Okay.
sir.
Thanks, Upendra and whole team for giving me opportunity. I'll go through the panelist. Dr. Vishnu Sharma, he's a consultant, Department of Hematology, SMS Hospital, Jaipur. Dr. Prakash Singh Shekhawat, Assistant Professor, Department of Clinical Hematology and BMT, National Institute of Medical Sciences, Jaipur. Colonel Kundan Mishra, Professor, Internal Medicine, Department of Clinical Hematology and Stem Cell Transplant, RNR, New Delhi. Dr. Mukul Agrawal, Assistant Professor, Clinical Hematology, All India Institute of Medical Sciences, Delhi. Dr. Shishir Seth, Consultant Hematologist and Blood and Bone Marrow Transplant, Indraprasth Hospital. Dr. Vinay Vora, Consultant Hematology and BMT, SRJ CBC Cancer Hospital, Indore. Dr. Mahesh R, Consultant Hematologist and BMT Physician, Sparsh Hospital, Bengaluru. With this, I welcome all my panelists, Dr. Vishnu, Dr. Prakash, Dr. Kundan, Dr. Mukul Agrawal, Shishir, Vinay, and Mahesh. All are present, or has someone information that all the panelists are here? Gitika, all the panelists are here?
Sir, only for Dr. Kundan, he will be joined later.
So say it again, who?
Dr. Kundan.
Dr. Kundan is not there. The rest of the people are there. Okay, so move to the next slide, please. We are going to talk about the hypocellular bone marrow syndromes, hypocellular the bone marrows. Before I go, I'll encourage people to have a question and answer, so that anyone who is among the audience want to have a questions from my panelists, I prefer that questions to be answered first. So we know about aplastic anemia, the severity and non-severity. There are parameters for that. This is a good cartoon showing a correlation between aplastic anemia, PNH, hypocellular MDS and MDS. And this shows what workup we have to do it and whether it is acquired or inherited. Next slide, please. There are very good cartoons showing that where the T cell immunity is affected, whether the B cell immunity is affected, whether the single chain lineage is affected, or whether the whole pancytopenia is there. Depending on that, you can have from ITP, autoimmune neutropenia to MDS. So this is probably a spectrum. There are many autoimmune mechanisms are there, which cell line is affected, and whether it's a T cell immunity or the B cell immunity. So there is some correlation between these parameters. Next slide, please. This shows the all the correlations which I showed it earlier. So these are the genetic hypocellular MDS, hypocellular bone marrow syndromes, so the congenital ones. These are the various causes, and the correlation has been depicted. Next slide, please. These are the major mechanisms. Either there is a direct damage, whether it's a physical or chemical, immune destruction, and constitutional genetic defects. And there are various treatments have been depicted. Next slide, please. This shows the percentage of Pnh clone. So it depends on how much Pnh clone is there, whether you have a classical Pnh or bone marrow failure syndrome with the associated Pnh clone. So you can have a bone marrow failure syndrome with the Pnh clone, and when the clone goes up, you will have a classical Pnh. Next slide, please. With this, I'll invite the panelists to answer. We usually keep hearing that the Asia has a higher incidence of aplastic anemia. I don't think we have many Indian publications. There may be few. And there's a one from Thailand, which was published in Blood. Can someone of the panelists, Shishir, we can start with Shishir. Can you say could be a reason? Or is there a multifactorial, or is it contributing to the higher incidence of aplastic anemia in Asia? Is Dr. Shishir there?
So, yes, sir. So there is no clear idea why means such incidents they are seen much in India, but or means Asian country, but there are especially in India and North India, means it had been seen means the use of fertilizers and various chemicals. They are means causing bone marrow aplasia more often.
Can I request
So
Dr.
environmental
Malhotra
factors,
to mute
packaging
himself?
and one of the playing role.
Okay, so we keep suspecting the fertilizers. Do we have any particular chemicals? Dr. Mahesh, can you elaborate more into the?
Yeah, so,
can pinpoint some chemicals.
I think one part is the chemicals, but I think what I read through various papers and various journals is that the cryptic genetic mutations, which are not usually picked up on most of the karyotyping, or even if you do clinical exome sequencing, sometimes these are the cryptic mutations which are causing these kind of abnormalities at the stem cell levels. That is what has been hypothesized as to why Asian continent has more aplastic anemia incidence when compared to other.
So we are saying that the Asian population has a more cryptic mutation.
Cryptic genetic mutations, and of course, more exposure to toxin and chemicals, but they have not clearly inculcated any of the toxins. But they are hypothesizing more that it could be a cryptic genetic mutations which are not easily identified on karyotyping or even on clinical exome sequencing.
Dr. Amrita Ramaswamy is asking what kind of question. Can you, Amrita Ramaswamy can be unmuted and she can say what she wanted to ask. Or? Dr. Amrita Ramaswamy? I think she's not. Go to the next slide. I think it's very, we need a more data, or we need a more studies to pinpoint what could be the reason why we have a higher incidence in comparison to the Western world. What's the correlation between aplastic anemia with the PNH and or MDS? I have shown a few cartoons. Can I request one of the panelists to say a few words about this correlation between these three diseases and AML?
I can take that.
Mukul, yes, go ahead.
So PNH and aplastic likely go hand in hand. A low PNH clone is almost seen in 40 to 50% of the aplastic anemia patient. But as the size of the PNH clone increases, the chances of being aplastic anemia are slightly lower. But there are certain patients who have a high PNH clone and a hypocellular marrow. Secondly, it is important to remember that the patient who of aplastic anemia who have received immunosuppressive therapy with ATG or otherwise, they tend to develop a PNH clone during the natural course of the disease further. So the PNH clone should be monitored every 6 monthly to at least a yearly in the patient who have received immunotherapy, immunosuppressive therapy, and it tends to rise and could be cause of isolated anemia in these patients 2 to 3 years down the line. PNH and MDS, although the association is less common but can be seen, aplastic anemia post immunosuppressive therapy is known to have a clonal progression to MDS AML. The risk is around 10 to 15% at 10 years. And these are considered to be high risk AML malignant transformations.
What could be the reason? The aplastic anemia is an acquired disease, and then probably you're saying the mutations are there which contributes to the progression. Yes, so there are some underlying mutations.
Yes. So there are certain underlying mutations which are there either inherently in the aplastic anemia clone, like the PIGA mutation or PNH or BCOR mutation, which are traditionally considered good risk mutations. Otherwise, the other ones, the DAT one, the AXXL, DMMT, or the
these are chip mutations.
These are the bad chip mutation, which kind of get a survival advantage in these patients, and might be associated with the clonal evolution to AML MDS.
So how do we know who gets a PNH and who gets a aplastic anemia? It's just who has a more PNH clone. Is there any mechanism who gets a more PNH clone and the less PNH clone?
Patient who have post immunosuppressive therapy, they tend their PNH clone tend to give a survival advantage and goes with time. Otherwise, at baseline, I am not very sure of any data that who gets more of a AA PNH and who gets a PNH AA.
Anyone more who wants to add on? Shishir, Mahesh, or anyone?
It depends upon the size of the clone also. If the clone size is smaller, usually 10 to 15%, then the chances of aplastic is more. Clone size is more, say around 70-80%, then it's usually classical PNH. It doesn't frankly go into aplastic or hypocellular. And we can also see that copy number variation, short arm of chromosome 6p, loss of homozygosity is also more associated with PNH.
Sir, one request. So I request all the panelists who is speaking, please mute yourself, unmute yourself. Else all the panelists, please mute yourself.
So everyone remains muted unless he is willing to speak. Next slide.
Yes, sir. Please.
Can we expect a chromosomal abnormalities? I think Mukul was talking about the chromosomal abnormalities was talking about the mutations. And if someone has a chromosomal abnormalities, what is the significance of these abnormalities? Shishir?
So, sometimes we are seeing the chromosomal abnormalities.
Shishir, you can open your video if you can. Means if you have a yes.
So sometimes we are seeing the chromosomal abnormalities in classical aplastic anemia. So there is no clear correlation, but there are few abnormalities. They are predilecting toward hypoplastic MDS.
So I mean, I'm not talking about the MDS. I'm talking about the aplastic anemia. Can we have these chromosomal abnormalities in some proportion of the patients? And
yeah, we are seeing in some proportion of the patients, we are seeing that some non-specific chromosomal abnormality. What is the relevance of that? Means it is nowhere reported.
Vinay? Dr. Vinay?
Yes, sir. So, sir, I think
everyone from the panelists can keep the video on if it is possible. So at least they are visible.
Right. So, sir, I think less than 10% of total aplastic anemia patients would have cytogenetic abnormalities on conventional karyotype. And these may be classic of myelodysplasia. But if we go into details and probably look into, say, molecular abnormalities, there would be more patients who would have some molecular abnormalities. Yes, but on conventional karyotype, probably less than 10% of the patients. As far as significance is concerned, I think we won't change the treatment. Initial plan of management would not change depending on the presence of cytogenetic abnormalities. But yes, if we have molecular abnormalities, prognosis and further management may change.
Next slide, please. I mean, this is on the mutational, the molecular level. The genetic abnormalities are found in roughly 50% of the patients with aplastic anemia. The genes involving, as Mukul said, the myeloid malignancies, when the DNTA, AXL1, BCOR, and BCORL1, they have a distinct chromosomal profile and the clinical impact. There is someone wants to talk about this 6p loss of
yes,
is Prakash or someone can talk about this. This is more common in and this has a significance. And over representation of these mutations are unique to aplastic anemia. They suggest the role of autoimmunity in the clonal selection. So the autoimmunity plays a dominant part in the clonal selection of these mutations. And obviously the myeloid malignancy related mutations are more likely to progress and more likely to have a progression to MDS and AML. So the significant numbers have a genetic abnormalities, and some of them just would be a autoimmune clonal selection and probably response to the immunosuppressive, and some are myeloid malignancy mutations which tend to progress to them MDS and AML. Next slide, please. Do you order it? So what test always is this thing whether I should order it a congenital bone marrow failure syndrome test, which test, and whether, I mean, can Vishnu wants to talk about this? Can I ask Dr. Mahesh to unmute, to mute yourself? Whenever you're not speaking, please mute yourself. Dr. Vishnu is there?
Sir, yes, sir. So stress cytogenetics for all patients below the age of 40 years. And patient who is affordable, especially young patients like age less than 20 years, NGS if possible.
So then you will send a NGS. Would you wait for the NGS? Okay.
Yeah. So basically, we have to wait for, if you are planning for immunosuppressive therapy, then we have to wait for reports to come.
Even for the transplant, the conditioning regimen and the selection of the donor, I mean, the stress cytogenetics will give you the majority. The rare ones will be the NGS. Mukul wants to comment on this?
Sir, I totally agree on this thing. So NGS will be sent usually at the time when you're planning, you have the diagnosis, you decide whether you're sending NGS or the stress cytogenetics. I don't see major benefit in sending both of them, as the NGS is likely to pick up most of the abnormalities, but yes, that individual practice may vary. So we are mostly sending stress cytogenetics for all the patients below, and NGS for patient who are planned for transplant or immunosuppressive therapy if they are usually less than 10 years of age. Yes, we do wait. Once it is sent, we wait for before starting on the proper treatment.
10 years or 20 years?
Sir, 20. Usually the guidelines say 20, but yes, definitely for less than 10 years we are sending.
Shishir wants to add on it.
So generally, we are doing stress cytogenetics for all, especially less than 40 years.
When you say all, means above 42.
Means that normally the congenital bone marrow failure syndrome, they are rarely manifest, means beyond 30, but the cutoff is given 40, so we are following that. But generally, they are usually in teen age. What we are seeing in clinical practice means even beyond 20, very few people they are positive for a clinical phenotype. NGS now widely available. Only the problem with NGS that it takes at least 3-4 week time, and sometimes if patient is not sick, patient is sick and it is not allowing means this much time. So how ethically means it is to send NGS and wait for NGS report. Sometimes it becomes difficult. So if patient looks stable, generally we are sending NGS and waiting for the report. If patient is sick, we are not waiting for the report. We are just going ahead for transplant. If means there is no morphological feature, no other features suggesting of bone marrow failure syndrome, we are just going for means the usual condition.
Anyone wants to add in this? Does everyone agrees or?
So for less than 45 years of age, I would like to do both NGS as well as stress cytogenetics. Very often, NGS has picked up certain mutations, especially dyskeratosis congenita. There might be some telltale signs in the patient, which we might often miss. Say, for example, certain patients may have nail dystrophy, certain patients may have just oral hairy leukoplakia without much of other manifestations. So these kind of telltale signs, physical findings can always be very tricky. And sometimes you may miss, and you may in fact offer them ATG, in which case it may not work in dyskeratosis congenita or other genetic or constitutional aplastic anemias. So
do you wait for the NGS report before you start any immunosuppressive or transplant?
Yes, I would wait. I would wait before I get at least a stress cytogenetics report.
Okay. Next slide.
Sir, I would like to add one thing, sir.
Yeah, Vishnu, go ahead.
Sir, at the very onset, we are sending PNH, and if PNH is positive, then most likely it is an acquired disorder. Then there is, I don't think there is an extra benefit of sending an NGS. Even stress also, but we are sending stress. We rarely find both stress and PNH positive. So for me, the most important PNH positive, then I expect all others to be negative. Then I send only stress. No.
Does the practice even in the pediatrics, or pediatric you tend to do more of a stress and then send a stress to everyone?
No, so PNH everyone, and then stress after the PNH comes, but I don't
Irrespective
send
of the
anything,
age.
sir.
Irrespective of
Yes,
the
sir.
age.
And so stress, when I send it till 45, not 40, 45, sir.
You're sending till 45. Next slide, please. How do we differentiate hypoplastic MDS from aplastic anemia? Vishnu?
Sir, yes, it is very important to differentiate between hypoplastic MDS and aplastic anemia. Sometimes it is very difficult to differentiate, but you can have like dysplastic features in bone marrow. Presence of Pnh clone again favors high Pnh clone favors aplastic anemia. Low Pnh clone can be seen in hypoplastic MDS, but primary hypoplastic MDS Pnh clone is usually like less than 10%. So it is high Pnh clone favors aplastic anemia. MDS defining cytogenetic abnormalities, and other myeloid mutations are more common in this hypoplastic MDS. And the marrow fibrosis, increased blast in the bone marrow favors diagnosis of hypoplastic MDS.
Someone does a CD34 staining also to find out whether this is aplastic or hypoplastic?
Yes, sir. Preferably it should be done.
Who wants to add on? Pawan wants to add on something? Pawan, Dr. Pankaj?
In aplastic, we...
Well, points noted, sir, but actually it is the pathologist who are supposed to give.
So you will accept it, whatever the pathologist says?
Yes, sir. If it is good pathologist, he would definitely differentiate between hypoplastic MDS and aplastic anemia.
Yeah, so sometimes it's difficult. So even these genetic...
Yes, sir. Cytogenetics and other CD34 staining, all these features will definitely, because in aplastic anemia, if they are associated with the megaloblastosis because of B12 folate deficiency, there can be some features mimicking this dysplastic features. So those things should be made into consideration as well.
Yeah, so we should keep a hypoplastic MDS in mind, and we should specifically ask for the morphological features, and the genetic mutations may favor towards the other chromosomal abnormalities may favor towards hypoplastic MDS. CD34 might help you into the differentiating between aplastic anemia and hypoplastic MDS.
Doctor, there is a brilliant presentation as always. Another couple of minutes to conclude, please.
Yeah, how much is the time now left?
3 minutes.
Only 3 minutes. We'll run. Next slide, please. Next slide. Does the Lymphoma increases the risk of clonal evolution? And because of that, would you not use it or use it for limited time? Quick the fire round. So the rapid fire round. Vinay.
So, sir, probably Lymphoma would not increase the risk in aplastic anemia and hypoplastic MDS. It may. So when we have increased number of blasts, probably we would be cautious when we use Lymphoma in these patients.
Aplastic anemia, there is no evidence so far it doesn't increase. So would you use it indefinitely, or you will be using because of the fear of clonal evolution? Would you limit it?
I think, sir, in aplastic anemia, I would use it upfront without any fear of having clonal evolution.
Mukul, you want to add on in something?
The studies say that it does not increase or it just accelerate whatever is happening. So something which the clonal evolution which you're seeing 5 years down the line, which we can see with within 1 year. So that is the current evidence, but the risk of overall evolution is comparable in both the arms.
Next slide, please. PNH has been done. Next slide, please. When do you, I think this has been discussed. Next slide, please. Maximum age to recommend upfront sibling transplant. Shishir. So when would you say someone is a sibling is available at full match? Would you do a transplant, or where would you prefer immunosuppression before the upfront sibling transplant?
So a patient is fit, there is no significant comorbidity, sibling is available, and patient is severe or very severe aplastic anemia up to 60 years, we are considering sibling transplant.
Your voice is breaking. So are you putting some age, or you're saying no age?
No, 60 years means beyond 60 generally means...
so if someone 59 comes fit, you will do a transplant?
Yeah, we'll do the transplant. Even if 62, if it is fit, and
Vishnu?
If they are severe or very severe aplastic anemia, we can go ahead for transplant.
Vishnu?
where up to 40-45 transplant upfront, and considering high transplant-related mortality and other risk,
Mukul?
immunosuppressive therapy for patient more than 45-40.
Mukul?
I go by the guidelines. American says 40. Go by that. Our transplant experiences are almost, we can say, best, can be best as compared to them. So when the guidelines are saying around 40, you can end up to 50 as per some of the other guidelines. But beyond 50, I will be very skeptical in offering upfront sibling transplant.
Is Prakash is saying something? Prakash?
Sir, to me it is 45, but if the family agrees and after explaining, because for other conditions we are extending, so to me it is 45. If the family is very keen and fit and fine both financially and physically, then I can stretch it up to 55, say 58.
Would you recommend a haplo upfront for anyone? Doctor, anyone who can answer it. Is the last question, upfront haplo transplant.
Upfront haplotransplant, I would like to do only for someone who has come with bad infections, because ATG would definitely take time.
Longer time to response.
What you want to do is take the patient into immediate hematological recovery, and that only transplant can do. So somebody with bad infections, yes, of course, a haplotransplant would be one of the options which I opt for my patients, and I would counsel that haplotransplant would help in a better early hematological recovery when compared to ATG, especially in the setting of severe infection.
Okay, because of the shortage of time, I cannot take the. I thank every panelist. We have gone through the initial discussions, and then we some questions. Time. With this, I thank the whole organizing committee to give us an opportunity. I hope the audience had a flavor of what the centers are doing as a practice. Hand over to organizers.
Thank you, Dr. Sunani sir, for that excellent moderation on hypocellular marrow failure, and all the panelists who have enlightened us on this topic. So now we are moving to the next topic. This is about optimal therapy for follicular lymphoma. Our next speaker is Dr. Pavan Kumar Singh. He is senior consultant and head Department of Hematology and Bone Transplant, Artemis Hospital, Gurgaon. Over to Dr. Pavan Kumar Singh.
Thank you, Dr. Vishnu, for inviting me for this. This is wonderful meeting going on. So the topic which I've been given is optimal therapy for follicular lymphoma, and the slides have been provided to me by Roche. I made some changes. So I will start. So follicular lymphoma, usual incidence is around 10 to 15%, and the Indian data also suggests almost similar kind of incidence, almost 4,000, 3,900 patients. So now if we see rituximab, so rituximab has really made very good improvements in terms of outcomes as a first-line therapy for treatment of follicular lymphoma in last decade, both the German study and when it was used as induction and as a maintenance, the PRIMA study, which clearly shows there is improvement in patients' outcome. So frontline treatment of follicular lymphoma, earlier we all knew that it was chemoimmunotherapy induction followed by maintenance with rituximab. It is the standard of care in previously untreated advanced stage follicular lymphoma. The median PFS is around 10 years and overall survival rate are at the approximately 80%. Despite these advances, most patients eventually relapse and it is associated with poor overall survival. The cure is the ideal goal for every disease and particularly malignancy. The current aim of follicular lymphoma treatment, it includes minimizing the number of lymph nodes and organ affected, then preventing the development of symptoms and treating the existing ones, improving quality of life and prolonging the remission rates. So what has happened in last few years as a first-line treatment for follicular lymphoma? So earlier it was rituximab and biosimilars was introduced during induction and as a maintenance. Then obinutuzumab came, the gallium primary data and gallium combined with chemo regimen data. Then PRIMA study which clearly showed the benefit of rituximab maintenance. Then update on R-Benda plus R maintenance in BRIGHT and maintain study. Then relevance data also supporting the use of rituximab, then gallium final analysis of this. Now, how to risk stratify and prognosticate? We all know the FLIPI score is there, so it is usually done prior to starting treatment. That is the baseline characteristics, and during treatment, we also the like interim pad or end of induction response, which may predict the outcome of disease, and the combination of markers. So FLIPI score, we all know that low, intermediate, and high, the probability of survival. Then the FLIPI-2, and it is also externally validated prognostic score. It predicts the PFS. Then Prima PI, it is a new prognostic score for follicular lymphoma based on bone marrow involvement and beta-2 microglobulin. Easy to score, and based on this, patients were categorized into high, intermediate, and low risk. Now, there is another on-treatment prognostic route like baseline PET scan. This is also important. Then end of induction PET clearly showed there was clear progression-free survival benefit and overall survival benefit at 4 years. Then combined PET at total metabolic tumor volume and end of induction PET, and other tools like MRD assessment, circulating cell-free DNA, then genetic and molecular risk profiling, and composition of microenvironment. These are of clinical interest for clinical trial. Now, treatment choices in follicular lymphoma, initial follicular lymphoma treatment. So first is workup. Usually it is done by routine histology, PET CT for staging, bone marrow aspirate biopsy, blood chemistry. Then Ann Arbor staging is there, localized disease, stage 1, 2, usually treated by the involved site radiotherapy. Then advanced stage follicular lymphoma, stage 3 or 4. Then we have to see the tumor burden. These are two criteria by which we can know the tumor burden: GLF criteria and BNLI criteria, the British and modified GLF criteria and BNLI criteria, positive. For low risk for this, if the criteria is negative, they can be put on wait and watch strategy. Or for old, frail patients, single agent rituximab is an option. For this criteria positive fit patients, they are usually treated with the 6 cycle of CD20 antibody, whether it is obinutuzumab or rituximab plus chemotherapy. The chemotherapy combination can be either bendamustine, CHOP, or CVP, followed by 12 doses of maintenance, either obinutuzumab or rituximab. These are GLF and BNLI criteria to know the tumor burden. So these are approved and emerging targeted therapies in follicular lymphoma. Antibodies, we all know rituximab, obinutuzumab, and other anti-CD20. Then CD19 is tafasitamab. Antibody ADCs like polatuzumab. Then PI3 kinase inhibitor. Then EZ2. These are epigenetic modifiers, tazemetostat. Then BiTEs again, and CAR T-cell therapy. These are in developmental phase. So red ones are in developmental phase. Black ones are already approved therapy. So what are the treatment goals? So basically, there can be patient goals, like patient usually are concerned with the quality of life, longer treatment-free period, and fewer long-term adverse effects. The physician goals are maximize time to next treatment, and prevent early progression, minimize treatment-related morbidity. So rituximab versus waitful watching in asymptomatic follicular lymphoma, is treatment needed? So based on this study, rituximab induction, and then as a maintenance, and the other group was without maintenance, and other group was waitful watching. So PFS was definitely in this study was better in rituximab group, though the overall survival at 6 years was almost similar in both the groups. Now, available treatment option for advanced stage follicular lymphoma with low tumor burden. We already mentioned that observation or rituximab monotherapy, high tumor burden, this combination with maintenance therapy. So these are chemoimmunotherapy. I will skip this. So this is R CVP, R job, R maintenance, and other is R job and R maintenance. So the other option is obinutuzumab in combination with. So which chemotherapy partner to combine with anti-CD20? So we have to see the parameters like age, comorbidities, the risk factors, long-term outcomes, patient preferences like hair loss, risk of infection, and which anti-CD20 to combine with this chemotherapy backbone is obinutuzumab or rituximab is based on risk, efficacy, safety, and tolerability. So, still study, RHL1 2003 study, R-Benda was compared with R-CHOP. And this study only focused on the induction. Maintenance was not given in this study. So, R-Benda compared with R-CHOP, R-Benda clearly showed the time to next treatment as a surrogate marker of PFS. It was better with R-Benda as compared to R-CHOP. So, the BRIGHT update, which focused on the long-term outcome in previously untreated indolent non-Hodgkin lymphoma and mantle cell lymphoma, R-Benda was compared with R-CHOP and R-Benda was compared with R-CVP. And end of treatment assessment was done, and after that follow-up was there. So long-term follow-up, R-Benda improves outcomes but not overall survival versus R-CVP and R-CHOP in previously untreated indolent non-Hodgkin lymphoma and mantle cell lymphoma. So clearly this curve benefits R-Benda. So BRIGHT study, post-hoc analysis, rituximab maintenance, it markedly prolonged the duration of response in follicular lymphoma after first-line R-Benda. Even after R-Benda, if rituximab is given as maintenance therapy, the duration of response was prolonged in follicular lymphoma. Rituximab maintenance did not prolong the overall survival in follicular lymphoma patient after first-line R-Benda. So usually this is very important because the advantage of R-Benda is that the rituximab maintenance may not be necessary. So suppose if we want to decide to give R-Benda, so induction, if only induction is given, that can also be sufficient. The relevance study design in which the R2 was compared with R chemo followed by R maintenance. So this study, the primary outcome was CR and CR unclassified rate based at 120 weeks of therapy. So it did not demonstrate superiority over R chemo for either of the co-primary endpoint, that is the CR and CRU and progression-free survival. Now coming to obinutuzumab, it is type 2 anti-CD20 monoclonal antibodies, and R1 is type 1, rituximab, Gazyva is type 2. So it is basically glycoengineered so that it increases the efficacy, and Gazyva, it has activity against rituximab resistant cells, and its combination with bendamustine could improve the efficacy in indolent non-Hodgkin lymphoma. The study which was conducted is the Gallium study, international open label phase 3 study, in which Gazyva was compared with CHOP, CVP or bendamustine versus rituximab with CHOP, CVP or bendamustine. So after CR or PR at end of induction, patients were put on maintenance in Gazyva arm, they put on Gazyva maintenance, and in rituximab, they were put on rituximab. The primary endpoint was PFS, secondary endpoint was overall survival, EFS, DFS, and time to next treatment. So Gallium study, primary analysis, progression-free survival, it was, benefit was maintained. So at 3 years, there was 34% reduction in risk of progression at the primary analysis, and at this PFS was maintained at 5 years of follow-up, and then we have the long-term follow-up of 8 years also study. The PFS benefit was maintained with G versus R chemo after 8 years of follow-up. Even after longer follow-up, these Gazyva showed clear benefit in terms of PFS. So it was favorable in various risk group also. So here we can say that it favors Gazyva plus chemotherapy in various subgroup analysis also. And it was also observed in intermediate to high-risk follicular, high-risk FLIPI score patients. So Gazyva versus chemo in FLIPI 2 to 5 subgroup analysis, this also showed benefit. The PFS was better. If we see in low-risk group, it has less as compared to in intermediate and high-risk FLIPI scores. It was clear benefit in terms of PFS. Time to next lymphoma treatment. Also, the Gazyva group showed improvement at 7 years of follow-up. Then PET response. This was clearly those patients who achieved CMR, they had longer PFS and overall survival as compared to those patients who did not achieve CMR after the end of induction. So this is the largest trial to assess end of induction PET in patients with previously untreated follicular lymphoma, and PFS was improved with G versus R chemo in patients achieving CMR. So those patients who were given Gazyva as compared to rituximab-based therapy, there was better. They were better in achievement of CMR, and which in turn translated into better progression-free survival. So overall survival, though it was almost similar in Gazyva versus rituximab. So safety-wise, it is almost similar, no adverse events. So what should be the preferred chemotherapy backbone with obinutuzumab? So obinutuzumab study. So it was compared with bendamustine, CHOP, and CVP. So it was better when it was compared with the bendamustine. Now, adverse events fairly well tolerated, and mainly in the CHOP group there was more cytopenia as compared to bendamustine. So maintenance therapy in follicular lymphoma. So this is a PRIMA 10-year update. Clearly showed those patients who achieved CR or CRU or PR, they were put on maintenance and observation, and it clearly showed the PFS was better in patients who were put on rituximab maintenance. The ESMO guidelines also showed these are the ESMO guidelines for relapsed refractory and newly diagnosed. So NCCN anti-CD20 therapies improving outcomes as a first line in last decade. So this is a study in which induction therapy is given with R. So chemo, when it is combined with R, the outcomes was improved. When the maintenance is given, it is better. And in Gazyva, both induction and maintenance, when it is used, the PFS and the patient outcomes were better with Gazyva in gallium study. When considering an frontline immunochemotherapy approach in follicular lymphoma, it is important to keep in mind that maintenance prolongs the PFS and reduces the risk of progression of death at 24 months. Obinutuzumab significantly increases the PFS and reduces POD24, especially in patients with high FLIPI scores. Toxicity of obinutuzumab is usually manageable and quality of life is maintained or improved compared to rituximab. MRD and PET seem to be important prognostic tools. And majority of patients in indolent non-Hodgkin lymphoma will stop responding to rituximab at some point in their course of their disease. So like we see, for 100 patients, 45 patients, they usually respond, and this response is maintained more than 5 years. 45 patients, for that 45% of patients who they die within 5 years of disease, and out of these, 23 patients are refractory to second line treatment. They have the poorer outcome. 23% of this group, they respond. They have more than 2.5 years to second line treatment, and median OS is for this group of patients is more than 5 years. 10% of patients, they are refractory to first line therapy, and treatment options for these patients are limited. They should be put on clinical trial, and outcome following salvage regimen is usually dismal, and they have PFS less than 1 year. So does POD, the progression of death at 24 months, influence the choice of next therapy? Yes, in PRIMA study, impact of treatment on early progression. So immunochemotherapy treatment associated with reduced rate of POD, but impact on post-progression survival is unclear in these patients. So what would be your preferred regimen in relapse refractory cases? We have option of bendamustine, R-benda, Gazyva plus benda plus G maintenance, R plus other chemo, PI3 kinase inhibitor, allogenic stem cell transplant, or clinical trial is available. The management of early progression after chemoimmunotherapy, PET should be done. If large cell transformation, they should be treated like relapse refractory DLBCL. If it is still follicular lymphoma, clinical trial available, ideally they should be put on clinical trial. If no trial available, is patient eligible for cellular therapy, they should be if anthracycline naive, they should be given anthracycline-based salvage regimen, and their PET response should go for high-dose therapy without stem cell transplant. If no, then Gazyva or bendamustine can be given. If there is not a candidate for cellular, usually they are put on palliation with maybe oral PI3 kinase inhibitor or lenalidomide plus minus obinutuzumab. So second-line treatment options. There is a CalGP Alliance study, phase 2 trial, rituximab plus lenalidomide in relapsed refractory setting. So it showed when len was combined with rituximab, the probability of progression and overall survival was better. Again, augment study also, this also supports the data. Augment safety wise, infection rates and cutaneous reaction rates are more common with rituximab len combination as compared to rituximab monotherapy. Phase 3 trial, again, it is showing the cytopenia adverse events were more and response rates were better with R-len induction followed by maintenance. The gadolinium study design, relapsed refractory indolent lymphoma, and in this, the Gazyva was combined with bendamustine and it was compared with bendamustine. Followed, the maintenance was given with Gazyva.
Dr. Pawan sir, excellent presentation as always. Another 2 minutes to conclude, please.
Yeah, sure. I'll just finish off. So Gazyva combination with bendamustine, it was better in relapsed refractory setting as well. It also resulted in getting more number of patients into MRD negative state. Then PI3 kinase inhibitors, overall response rate in the range of 50 to 60%, though the CR rates are very less than 10%. So can be kind of palliative treatment in patients not refractory to it. Then T-cell bites. So these are various bites available. So in relapsed refractory follicular lymphoma, the CR rates are excellent. Various studies showing in the range of 50 to almost 100% when it is combined together. So new challenges in the evolving follicular treatment landscape. I'll just skip this. So treatment algorithm. I'll just few 3 slides. So we have to prognosticate based on the FLIPI score is the most commonly used. Then symptom, no symptoms, mild symptoms, or the patient priority, long-term remission. So choose among if mild symptoms, non-chemotherapy based rituximab monotherapy is an option for these patients. Asymptomatic patients can be put on wait and watch strategy. Patient with high tumor burden, they should be put on chemotherapy with anti-CD20, as I mentioned. In selected cases, rituximab plus len when there is patients are unfit. For low tumor burden, stage 1-2, involve field radiotherapy plus minus rituximab, or with stage 3-4, wait and watch. In selected cases, rituximab monotherapy can be given. For relapse and progression, we can give any combination of these or immunotherapy. For high tumor burden, I already mentioned first line treatment is usually given as chemotherapy with anti-CD20, and in selected cases, rituximab monotherapy with lenalidomide. For elderly flare patient, rituximab plus lenalidomide combination can also be given for these patients. At first relapse, we can change therapy. We can add on anthracycline. Late relapse progression, this put on clinical trial if available. Autologous stem cell transplant can also be given. Radiotherapy or the PI3 kinase or bites if available. So I'll just stop here. Thank you.
Thank you, Dr. Pawan Kumar Singh, for that excellent talk on how we can optimize our treatment therapy for patients of follicular lymphoma. Now we'll be moving to our last talk of this today's session. So last talk is by Dr. Manoj Mahajan. He is Director Oncology Services, Senior Consultant Medical Oncology at Pacific Medical College and Hospital, Udaipur. He will be talking about shifting treatment paradigm in patients of follicular lymphoma. Over to Dr. Manoj Mahajan.
Am I audible?
Yes, Dr. Manoj. You can start your video also.
Yeah. First of all, I would like to thank Dr. Upen for giving the opportunity. So the talk would be based on Dr. Pawan Kumar Singh sir has done my job quite easy because he has taken extensive review of the follicular lymphoma treatment.
Dr. Manoj, you can share your video also.
Okay.
Actually,
the connections is not very smooth.
No problem. No problem.
Okay. So I'll be discussing the mainly obinutuzumab or Gazyva trials in follicular lymphoma and indolent NHL. Mainly, this is the disclaimer. So I'll be discussing gallium and gadolinium data which sir has few of the slides are quite common in as per the previous slides. So if we come to the overall improvement in last few decades in terms of follicular lymphoma, so chemo rituximab has added a significant age to the chemo, which was proven in the GLAZ 00 trials and M39021 trial. And the next course, or it has almost doubled by the prima, with adding the concept of maintenance in follicular lymphoma versus single observation after our chemo. It has next slide. So it has reached the median PFS of nearly more than 10 years, which is quite unheard of. Again, it is quite impressive. And the OS rates at 10 years, nearly 80%. So the maintenance therapy with the rituximab has given a new concept or new age to the treatment paradigm. But despite all these advances, most patients will eventually relapse. And so early progressors after first line treatment is always associated with the poor overall survival. Next slide. So as we have seen in the earlier presentation, mainly there are two types of anti-CD20 monoclonal antibodies, type 1 and type 2. The type 1 is mainly associated with the complement-mediated toxicity and ADCC, which is like antigen-dependent cellular cytotoxicity. But in terms of type 2, it has edge over, apart from the ADCC, it has also activity on ADCP, antibody-dependent cellular phagocytosis. So it has theoretically, looking in the forming in the context, theoretically it has a benefit over the rituximab. So it is the only glycoengineer. How does it act? It is by glycoengineered. This is the first glycoengineered molecule, monoclonal antibody. It removes the sugars from the Fc region and it increases the binding affinity to and activation of immune effector cells to enhance ADCC and ADCP. So mainly the functional activity changes with the type 2 antibody, monoclonal antibodies. Next slide. So that is why it gives the edge to act against rituximab resistant cells as well. So this was the context forming. So how did we prove it? Like it was proved in a gallium trial, which is a multicentric open label randomized parallel group phase 3 study in patients with previously untreated advanced indolent NHL, including follicular lymphoma or marginal zone lymphoma, followed by Gazyva or rituximab maintenance in responders. Next slide. So the study schema was like this. Next slide. So the study schema was age more than 80 years, follicular lymphoma grade 1 to 3A with splenic nodal extranodal MZL, stage 3-4 or stage 2 bulky disease more than 7 centimeter requiring treatment, ECOG PS 022, and target follicular enrollment was around 200. So induction was given with the Gazyva, which was for the first cycle. It was given in 3 weekly fashion, day 1, day 15, and then subsequently once day 1 of every cycle. If it is 8 weeks, there are like 2 regimens, 3 weekly regimen versus 4 weekly regimen, cycle 2 to 6 and cycle 2 to 8. And it was combined with the CHOP, COP or bendamustine versus rituximab as the standard doses, and the maintenance was given in a patients who had CR and PR. Primary endpoint was PFS and secondary endpoint PFS, IRC assist, and OS, and other factors, TNT and EFS. So we'll see what were the results of this concept and how did we end towards the proof of this concept. Next slide. So if you look at the data, it's quite well the characteristics of the data, which is quite well matched. Stage 3, stage 4 patients were nearly 90% of patients. Nearly 1/3 patient has B symptoms. Nearly 50% had bone marrow involvement. Nearly 2/3 has extranodal involvement. 45% had a bulky disease. So it is most of the time, this is how the most patients present to us in Indian setting as well. Next slide. In terms of the FLIPI category, intermediate 2 and 3 constituted nearly 80% of the patients in both the arms, Gazyva as well as rituximab arm. And chemotherapy regimens were randomized. It was not randomized, but used like bendamustine, CHOP, and the COP were the backbones. And even the Asian population was nearly 15% in both the arms. Next slide. So if we see the characteristic of each individual chemotherapy, we can highlight 2-3 things. Like again, even in the trial, nearly 3.4% patients were more than 80 years and used bendamustine as compared to the chemo and COP. Even in the Charlson comorbidity index score, more than one comorbidity were nearly 23% patients, again more than what CHOP and COP usually. So again, in Indian setting, bendamustine is quite commonly used, or even in the Western setting or clinical trial setting, similar things has been observed. Like even the age, advanced age and multiple comorbidity, bendamustine is the backbone. And if the FLIPI high risk and bulky disease, then more of use of CHOP regimen. So next slide. Coming to the primary endpoint of investigator assessed PFS, if we see the stratified hazard ratio of 0.66 with significant p-value with the median follow-up of 34.5 months. So 3-year PFS was 73 months versus 80 months. So it was nearly quite significant difference of 7 to 8 months. Next slide. Core efficacy, this again we have seen. So most of the subset in this subgroup favored Gazyva plus chemotherapy arm, and except FLIPI low score where it tend towards the rituximab tomi, rituximab plus chemo, but the hazard ratio in the FLIPI low risk patients was not consistent with the overall population. So sub-analysis of these patient subgroup by gender did not confirm the FLIPI effect. So this would be probably a chance finding. Rest all other subgroups benefited with the Gazyva and chemo. Next slide. So this is the latest updated data till 31st of October. Again, the hazard ratio is maintained. 5-year PFS is 63% versus 70%, favoring Gazyva again nearly 7%. Next slide. So it is interesting to see what were the effects in the chemo arms or backbones were different chemo arms. So if we can see, all patients definitely benefited at the end of 3-year PFS with the Gazyva. In bendamustine arm also, it was Gazyva benefited. In the CHOP regimen, it is not statistically significant. Hazard ratio is on the lower side. Though this study is not designed or powered enough to compare differences between R chemo and Gazyva chemo within the chemo groups, but it consistently maintained the superiority of the Gazyva plus chemo relative to rituximab plus chemo in across all subgroups. Next slide. So IRC associated PFS, again the hazard ratio is 0.7 and 3-year PFS of 77.9 versus 81.9 months after the follow-up of 34.5 months. Next slide. TTNLT is like time to next anti-lymphoma therapy. Again, HR is 0.68 with significant p-value at the end of median follow-up 34.5 months, or you can see it is the median follow-up, and both the graphs are going parallel. So this probably the additional updated analysis may show the additional advantage. Next slide. OS benefit. It is again, as we have seen, the OS is nearly 80% at the end of 10 years. So we might need further time. The OS analysis is not very, there is not significant p-value. So statistically, it is not significant. But over a period of time, the graphs are like still matching, but they may diverge. Next slide. 5-year overall analysis. 5-year OS is 90% in Gazyva chemo versus 89.4. Again, statistically not significant, but favoring numerically towards Gazyva. Next slide. So if we see the induction responses, overall response rate is slightly better with the Gazyva, but CR rates were slightly higher in the rituximab arm, and PR rates were harm. But these were no clinically relevant differences between these two arms of ORR and CR rates. Next slide. The value of MRD is yet to establish in the indolent lymphomas. But if we go with the MRD status negativity at the mid induction and end of induction, it is again favoring the Gazyva plus chemo arm. So nearly 100% patients in the Gazyva chemo arm who were still MRD positive at end of induction had MRD below the limits of quantification versus 63% in the rituximab and chemo arm. Next slide. So one of the important criteria is progression of disease within 24 hours or POD 24. It is associated with the reduced overall survival in the follicular lymphoma patients, as most of the 20 to 30% patients recur in within 2 years. So it is strongly correlated with the higher risk of death and inferior OS. So is there any change with the Gazyva? We'll see that in the next slide. So if we see R chemo had POD events nearly 98 and R Gazyva plus chemo 57. It has reduced. So G chemo reduces the risk of POD 24 events over 2 years by 46% versus R chemo. So this is a quite significant marker which improves the OS in terms of decreasing the, theoretically it improves. Next slide. So post-progression survival POD versus later PD at the median of nearly 7 to 8 years, 43% of POD 24 patient had died, and 3.7% patients with later PD had died. Next slide. So PFS in high risk intermediate to high risk patients. Again, Gazyva has an edge over in these patients, where 4-year PFS rates are 64% versus 78%, quite significant. So in high risk patient, Gazyva definitely helps. Next slide. So other outcomes, if we see OS at the 4 years, 88% versus 91. Patients had NLT at 4 years, 71 versus 81. Cumulative incidence of POD 24 events were less in Gazyva arm. Mortality after POD 24 events nearly matching. Grade 3 events were slightly higher in Gazyva arm, and grade 5 events were almost equal. Next slide. So, what was the analysis with the gene expression analysis? If we do a PFS by 23 gene signature and chemotherapy backbone, so 23 gene signature high risk group was not associated with the PFS, and there is significant interaction in terms of using the response to the bendamustine in the high risk patient. Next slide. PFS by T effector signature, where the high risk group was not associated with the PFS, and there is again similar, this T effector signature also showing the bendamustine usage and the response to the bendamustine. Next slide. So histological transformation happened in nearly 40%, nearly 3% of the patients, which has more or less the 3 criteria which was associated with the elevated LDH, patients who were baseline anemia with hemoglobin of less than 12, and male gender has a higher risk of transformation. Next slide. So to summarize the Sept event, like grade 3, grade 5 events were more common in Gazyva arm, and adverse events leading to discontinuation was more or less similar in both the arms. Next slide. So if we see the overall effects, the infection and neutropenia, thrombocytopenia, and infusion-related reactions were common in the Gazyva arm. Hematological toxicity was more common in Gazyva arm. Mainly the infection and infestation, as defined by the MED-DRA SOC, occurred in 15% of patients in the ARG arm and 20% in the Gazyva arm. Next slide. So we have to be, in short, we have to be careful while continuing the treatment with the Gazyva in terms of infection and infestation. So to primary hazard ratio of 0.66 and extended updated analysis showed hazard ratio of 0.76. The efficacy of G-based regimen is consistent across the different chemotherapies used, and more G chemo treated patients achieved MRD negativity and AE, also adverse event consistent with the known safety profiles. Next slide. So we'll just quickly flip through the next slide. Anti-CD20 therapies has improved, like it has given the edge over the Prima and the Gallium study showing the importance of Gazyva beyond the rituximab maintenance and replacing the rituximab with the SOC and in induction as well as in maintenance. Next slide. So in relapse refractory follicular lymphoma, as this slide has been shown, we'll just go through the next slide. Next. So as we know, nearly 45 patients progress or die within 5 years and 10 are refractory. 45% will have a long-lasting responses. So in the refractory patients, nearly half of them will be refractory second-line treatment. Nearly half will respond for more than 2.5 years. So in half patients, median OS will be 2.5 years, and rest of the half will be, the median OS will be less than 3 years. So the unmet need is to improve their survival or improve their PFS. So the study was done. Next slide. So what are the standard options we have? Either bendamustine monotherapy, which gives the median PFS of 9.3 months. Tocilizumab median PFS of 10.4 months. Ofatumumab median PFS of 5.8 months. Adalimumab. So all the options gives the median PFS of less than 10 months or 11 months. So gadolinium was designed. Next slide. Which addressed this issue, which is an open label multi-center randomized phase 3 study. Next slide. So it included R refractory patients randomized in 1:1 fashion versus bendamustine mono versus Gazyva plus bendamustine. The dose of bendamustine was slightly higher in the monotherapy arm as compared to the combination arm. And then subsequently, Gazyva maintenance was followed. Primary endpoint was PFS and secondary endpoint was OS and other parameters. Next slide. Key baseline characteristics were quite well matched. Most of the patients were advanced diseases. Nearly 70% patients had intermediate Lippi 2 or 3. Next slide. Extranodal involvement were present in nearly 50 to 60% patient. Nearly 1/3 patient had bulky disease, and bone marrow involvement was again in nearly 1/3 patient. So it was quite. Next slide. Treatment patient characteristics were quite well matched in both the arms. Next slide. So if we see the treatment history in such patients, it is again well matched in both the arms. Nearly 40% patients had 1 line, nearly 35% patient has 2 lines, and 20% had more than 2 lines. Next slide. Treatment history was, so what were the results? So if we go by the PFS, so at the end of nearly 2 years, the ratio was 0.55 with quite a significant p-value. And if we see the graph, it is going towards the PFS going towards the 4 to 5 years. So there was 45% reduction in the risk of progression or death with the Gazyva. And if we see the OS in this population, again, at the end of nearly 31 months, hazard ratio 0.58, and median OS is not reached versus 53 months. So, and the graphs are quite parallel. So hopefully the OS is definitely will be significant over a long-term period. Next slide. So if we compare the OS in indolent NHL and OS in follicular lymphoma with both the arms, Gazyva arm and in the indolent NHL, it was quite significant with hazard ratio of 0.67 with significant p-value, and in follicular lymphoma, hazard ratio of 0.58 with significant p-value. So in both the second line setting or refractory cases, Gazyva has a very good OS survival also. Next slide. So if we compare them with the subgroup analysis, most of all the subgroups are favoring the Gazyva arm. Next slide. Next slide. So summary of the safety with the primary analysis, both the arms are comparable and there were no unexpected safety signals for Gazyva. Next slide. To summarize, so in indolent or refractory cases, Gazyva is a combination of Gazyva with bendamustine is a better choice. It gives a PFS benefit as well as OS benefit, but there is significant improvement in the updated analysis of the OS. So clinical meaningful PFS with the combination arm with the G and B, Gazyva plus bendamustine is observed in the gadolinium, and it is the first randomized evidence of benefit of for the novel anti-CD agent. Next, thank you.
Thank you, Dr. Manoj, for that wonderful talk on the shifting treatment paradigms in case patients of follicular lymphoma and using obinutuzumab in frontline and relapse refractory setting patients. So finally, we summarizing today's discussion on what had happened in the EHA 2022 at Vienna, Austria. So our first talk by Dr. Mukul Agarwal, he talked about best of EHA 2022 on CLL. So he showed about the limited duration of therapy when using ibrutinib with venetoclax. He also talked about the NCRI trial showing FCR compared to ibrutinib plus venetoclax with overall response rates of 86% and 75% of the patients achieving MRD negativity with the combination of ibrutinib and venetoclax. Good responses with ibrutinib, but these patients, none of these patients attain MRD negativity. Regarding Gaia Trial, triple combination of ibrutinib plus venetoclax plus obinutuzumab showed MRD negative rates better with the triple combination at 15 months. Also about the Elevate TN trial 5-year updates, that PFS survival of PFS benefit of 75% with acalabrutinib arm as compared to the obinutuzumab and chlorambucil arm, with overall response rate better with the acalabrutinib arm and undetectable MRD with maximum with acalabrutinib arm. He also showed about Isquia trial, wherein zanubrutinib had better health-related quality of life when compared with bendamustine rituximab. About Alpine trial, zanubrutinib when compared with ibrutinib showed better adverse event profile with zanubrutinib as compared to the ibrutinib. He also talked about pirtobrutinib in BTK inhibitor failure patients. So this is a new agent wherein those patients who have failed BTK inhibitor, this agent can be used in combination with venetoclax or rituximab. Lastly, I talked about CAR T-cell therapy in patients of CLL. Then we had a great panel discussion by Dr. Pnh Malhotra. He moderated the session very well on optimal sequencing of therapies in CLL patients, and that was very well discussed by our esteemed panelists on the practical aspects of CLL patients. Then we had a session 2 on MPN that was covered by Dr. Pawan Kumar Singh. He discussed about the evolving treatment paradigms in myelofibrosis patient and update from EHA 2022. He talked about the rationale for early use of Rexolotlip in myelofibrosis patients. So we should Rexolotlip early in patients of myelofibrosis. Otherwise, we will have good responses. So if we use the duration of starting Rexolotlip is more than 2 years, responses are less. Those patients who are having larger spleen, transfusion dependency, low platelet count, those patients in intermediate 2 or high risk IPI, and those patients who are using low dose of Rexolotlip, the results are inferior in those patients. So, and he also talked about that anemia is not a contraindication for use of Rexolotlip, and those patients who develop anemia during Rexolotlip treatment, that doesn't affect the benefit of JAK inhibitor. Also, the role of adaptive and allogeneic stem cell transplantation in myelofibrosis was very well dealt with by Dr. Pawan. Then we had very excellent panel discussion moderated by Dr. Dinesh Gurani sir on the hypocellular bone marrow failure. That was very well discussed by our esteemed panelists. Then we had the talk by Dr. Pawan Kumar Singh on optimal therapy in follicular lymphoma patients using in first line bendamustine rituximab versus R-CHOP versus R-CVP. So bendamustine favored over other agents. Also about the bright study wherein rituximab maintenance was used, and this showed a marked prolongation of duration of response with follicular lymphoma patients in first line after use of BR. But there was no significant prolongation in the overall survival rates of with this arm. Regarding relevance study, wherein rituximab and lenalidomide was R2 was compared with R chemo, that was followed by R maintenance. So R2 did not demonstrate superiority over R chemo in regards to CR rates and PFS. Regarding Gallium study comparing obinutuzumab combined with R-CHOP, CVP, or bendamustine, when it was compared with rituximab, when it was combined with CHOP, CVP, and bendamustine, PFS was improved with G versus R chemo over long follow-up of up to 8 years, but overall survival was similar with G as versus R chemo, with no new safety signals demonstrated with this. 10-year updates of Tumor trial showed that PFS of about at 10 years was 15% with rituximab maintenance as compared to 31% those patients who was followed on observation. Lastly, we had a great talk by Dr. Manoj Mahajan on the shifting treatment paradigm in follicular lymphoma patients, wherein G chemo plus G maintenance showed superior PFS versus R chemo plus R maintenance. Further, G chemo treated patients achieved better MRD negativity rates with better PFS and overall survival. Also, that clinically meaningful PFS improvement with G bendamustine observed with gadolinium trial in those patients not benefiting from rituximab-based treatment. Finally, we had, I want to thank Dr. Hemant Malhotra sir for his welcome note and blessings. I'm also thankful to all the speakers, Dr. Mukul Agarwal, Dr. Pawan Kumar Sen, Dr. Manoj Mahajan, and also I'm thankful to our moderators, Dr. Pankaj Malhotra, Dr. Dinesh Gurani, all our esteemed panelists. I'm also thankful to all the delegates, pharma friends, Mr. Tarunji and his team for making the second day and final day of our Hematology Update 2022 from the best of EHR 2022 a great success. And I am thankful to all of you who have joined and spared your evening to make this event a successful one. Thank you once again and a good night. Over to Pawanji, over to Tarunji.
So thank you so very much, Dr. Upendra sir, for such a kind words and elaborate closing. So on behalf of my colleagues, Geetika and Ankit and the entire organizing team, so thank you. Have a nice weekend. Stay safe, stay blessed. Good night. Till we meet again for a physical meeting. Good night to everyone.
Thank you. Good night, everybody. Thank you.
Thanks, sir.
Thank you.
Thanks, sir. Good night,
Thank you,
doctors.
sir.